There were 4 batches. I looked at comments by students. The raw data is there. In fact, anybody can repeat that study. But if you go to different Nigerian WhatsApp forums, your American Association, if MDCAN, many of you commented. You go to NMA, people commented. Very many platforms, people commented. So when you look at all the things that people have said about this Jambe glitch, you now merge them to now invoke psychological civil society. That some people are just about universal justice. Universal justice, whether you are involved or not. But some people, especially depending on where they come from in Nigeria, are kind of relying on bureaucracy. So it shows their reasoning at a very low, much lower level than those who talk about social justice. And finally, of course, those who are
addressing the question. Then on a final note, any question for Dr. Igwebike? Any question for her? Okay, see Professor Ugochukwu online. And Professor Wakwe.
Thank you, Dr. Igwebike. What about presumptive tuberculosis in the adults? In the teaching hospital here, where you could take their sputum and test, and where you have chest x-rays. In children, we tend to have a lot more presumptive because of the difficulty in making diagnosis. But in adults, you don't have that same difficulty. So what was the number? I don't know. Maybe to now give you opportunity of giving us a little bit more detail. What was the number you have, you know, that are presumptive, and why are they presumptive?
A prof have withdrawn because the other question I have for her is just tell us about their study design. What was study design?
Thank you for the comments. Prof, you asked about the samples. I went ahead and defined what presumptive TB patients, who they are. They were known as TB suspects. Because I didn't have time to, you know, do the detailed presentation, actually, one of the major limitations of this study is that it involved only NAUTH Center. Had it been we involved other centers?
No. I think you have tried to answer it because we don't have time. The other question, Nko, the design. What study design you used?
Okay, the study design was descriptive cross-sectional study. Descriptive cross-sectional study.
Okay, thank you. Thank you. Please, on the note, we would like to have, for finalize it, all the presenters should come in front. We'll have a group photograph with Adora. Just quickly. All the presenters. Professor Goju should also join the presentation.
Please, let's welcome him. Thank you, sir. I'll hand the microphone over to him.
Good morning, my teachers and colleagues. We will go straight ahead with the second session. We're already 1 hour behind schedule, so we'll start straight on. Dr. Nduku is the first presenter. Please, can you come up? We will take all the presentations and take the questions at the end. 5 minutes each, please. 5 minutes.
Good morning, ladies and gentlemen. Representing the fractured neck of femur in children, a case report. Application legal vascular necrosis, premature fascial closure. You can see the anatomy of the femoral neck. You can see once a fracture around the neck, the head only depends on the ligamentum fovea, which is inadequate. Now, displaced fractures are managed surgically with varied options based on the age, depth classification, and the degree of displacement. And the options include the use of multiple K-wires in children less than 5, percutaneous cannulated screws, and femoral neck in older children. These constructs are often supported with plaster cast. Now, this is the depth classification, which classifies femoral neck fracture in children into 4. Type 1 is less than 10% in occurrence, and it's like a Salter-Harris type 1. Type 2 is a transcervical, which is what the index patient had, and is the commonest. Type 3 is a cervical trochanteric, and 4 is of the balcony of a one-story building by the 9-year-old elder male sibling. She fell on a hard cemented floor with the legs and instantly developed severe pains and inability to bear weight on the right lower limb. She was brought to the clinic support. Our most recent radiograph shows radiographic union with no complication. This is a preoperative radiograph. You can appreciate the fracture at the right side of the neck. And then you can, this is intraoperative at the fracture site. Now, femoral neck fracture in children is rare, like I said. Type 2, which is the most common, is what the patient had. As in the present case, a displaced fracture significantly increases the risk of complications, such as avascular necrosis, due to disruption of the femoral head blood supply. Numerous studies recommend urgent anatomical reduction and stable internal fixation, ideally within the first 24 hours, to minimize vascular compromise and reduce the incidence of AVN. In the index case, reduction was achieved within 24 hours by close manipulation under image guidance and painfully done for the index patient. The postoperative course of pediatric femoral neck fracture is heavily influenced by the quality of reduction, the stability of fixation, and the timing of intervention. AVN is the most serious complication, has been reported in 17 to 47% of cases. And the absence of early radiographic signs of AVN in our case is encouraging after we have done the check radiograph. And prompt treatment is key to achieving good outcome. Surgical reduction under image guidance with the C-arm enables anatomic reduction and stabilization. These are my references. Thank you for your attention.
Thank you, Dr. C.U. Nduku, for that presentation, case report on femoral fracture, and also for keeping to time. The next presentation is Let's Presenting Cauda Equina Syndrome, Management Challenges, a case report and review of the literature by Dr. Nduku C.U. Please move on.
Good morning once again. Bundles. As we all know that the spinal cord ends at the level of L1 and continues as a cauda equina fibers. It's a relatively rare condition, which, as documented in the England Journal, is about 1 to 3 per 100,000 cases. The symptoms and signs of CES include low back pain that radiates down the legs, numbness around the inner region, which we call saddle anesthesia, loss of bladder and bowel control, and impaired sexual function. The common studies have shown significant delays in presentation of cases of CES, which actually impacts on the outcome. However, there is some evidence which shows significant recovery of function in late presenting cases when intervention is offered late. So the aim is to highlight the importance of surgical decompression of cauda equina fibers irrespective of time of presentation. This is a 43-year-old male who presented with a 2-week history of persistent low back pain, radiating vision on the right. Clinically, he was looking healthy. In fact, walked to the entry on the right. There's a neurological assessment based on the different myotomes. You can see that on the right, from L3 down was 3, while for tenderness around the lower lumbar area. This is MRI of the patient. If you follow the cursor around the L5, there was a huge L5S1 disc, there was a huge disc prolapse that was compressing both the cord and the exiting nerve root. This is the axial view, which also shows he had the comprehensive hemilaminectomy and right-sided foraminotomy with discectomy at L5-S1 level. Actually, 5 days after presentation. So if you add it to the other one, it means he has stayed about 19 days from the onset of symptoms. There was preservation of spinal stability post-op, and it was done under GA with cuffed endotracheal intubation. He had post-operative physiotherapy commenced from the second day post-op. The patient regained bladder function within 21 days, though with occasional nocturnal dribbling. Bowel function returned on 30 days post-op, though with some difficulty. They had to do some manual evacuation because of hardness of the stool. There was marked improvement in the lower limb motor function, and the patient now ambulates with a walking stick, though saddle anesthesia still persisted. Now, late presenting caudal spinal syndrome remains one of the most challenging entities in spinal practice. This is due to the diagnostic delays, systemic barriers to prompt management, and the variable outcomes. The present review highlights the complex in such cases. Delayed and misdiagnosis was found in some studies to be responsible for delayed surgical treatment. This was more likely when fewer features of CES were established at the time of presentation, when the features are not very classical. Only 19% of patients, according to the JLO et al., present, but was misdiagnosed at the primary care level. Late presentation for the clinical care is a key challenge. This is often multifactorial due to misdiagnosis, the primary care setting, lack of access to advanced imaging like MRI, socioeconomic barriers. The index patient had no money at the time of presentation, so he had to run around, beg friends to contribute. And of course, atypical clinical outcomes with early surgery. However, Kuresh and Sell reported that although early surgery improves outcome, meaningful recovery remains possible even when the compression occurs several days later, as in the index case. Shapiro noted substantial improvement in leg pain and saddle anesthesia even after delayed intervention, and so other studies. Though bladder outcome is reported as the weakest domain of recovery in late presenters, and in this case actually regained bladder function within 2 weeks post-op. So surgical decompression should still be done, and that is our recommendation. Presentation remains a challenge, especially in our resource-constrained client environment. Thank you very much. These are my references.
Thank you very much. See you, Ndoku. Third presentation will be by
Good morning, everyone. I'll be presenting types and severity. Is an inherited autosomal recessive disorder, and it is caused by substitution of valine for glutamic acid at position 6 of the beta-globin gene of the hemoglobin. And it causes sickling of the red blood cell, resulting in chronic hemolytic anemia, vaso-occlusion of 3.6 to 66%. Sensorineural hearing loss, though not uncommon in adult with sickle cell anemia, is caused by microvascular occlusion, causing cochlear ischemia, and also from labyrintine hemorrhage and labyrinthitis ossificans. And those who present with conductive hearing loss and even mixed hearing loss is attributed to increased susceptibility to infection for immunologic dysfunctions among sickle cell anemia patients. So thoughts that will come, we conducted over a 1-year period for patients confirmed with hemoglobin SS genotype in steady state between the ages of 18 to 55, and who were enrolled by convenient sampling technique, and it was carried out in hematology and otolaryngological clinic in NAUTH. These were in the inclusion and exclusion criteria. An interview administered questionnaire were used, the biodata, clinical history, the findings on sample size was 70, which was determined using Cochrane formula. Their pure tone average for better hearing ear was used for hearing threshold assessment of each participant. The severity and the type of hearing loss that was used in the study was WHO. The males were more, accounting for 53.4% of participants, 5.5 of the study participants self-reported subjective difficulty in hearing at the time of recruitment, and group of 46 to 54, that is 33.6. And the females had a higher hearing trade. Types of hearing loss presented, the sensory hearing loss had the highest prevalence, which was 57.5. Using the WHO grading classification of severity of hearing loss, majority of the participants had mild hearing loss, with %. This was similar to the studies of Adekoya et al. And Onokaya, who got 69 and 66 respectively. However, some other authors like Okebi and Sarak had lower incident prevalence in their own study, which they accounted to be because of the differing specific hematological profile of sickle cell across the different locations. But Jebi mentioned it as a limitation in their study because of their sample size. Their sample size was 43. But in our own study, the high prevalence could have been accounted for by low awareness. Similar findings by Onakoya and Okibi, and they attributed it to end organ damage. And majority of the females had higher hearing threshold and is associated with increased hemodynamic stress that may occur only during audiologic assessment. This was similar to the findings of Onokaya and Ajabe, and the loss among adults with sickle cell was found to be 67.1%, which was mostly mild in 61.6% of them, and the hearing loss according to WHO. So making most of them not know that they have hearing loss. So the recommendation is that patient education to increase awareness of hearing loss as a complication among adults with sickle cell in our environment. Thank you.
CEO. Electrocardiographic characteristics of adult persons living with HIV in NAUTH.
NAUTH cross-sectional study. Like we know, HIV is a major global health challenge. About 38 million people live with HIV. And Nigerian active antiretroviral therapy, patients now tend to live longer, and cardiovascular complications are actually more and more positive patients on heart who were above 18 years. We excluded anything that could affect the ECG, such as medications, those who are on medications such as beta blockers, non-dihydropyridine calcium channel blockers, people with a history of ventricular hypertrophy, biventricular hypertrophy, QT interval, QT dispersion, and data was analyzed as listed. So persons had one or more ECG abnormality, and left ventricular hypertrophy and prolonged QT. About 10.9% had right ventricular hypertrophy, about 5.5% had right bundle in adults RVD positive patients on heart. Like I said, the proportion of ECG abnormalities was 61.8%, and this is a high proportion, and it's similar to what others have found in atrophy. Was the most common ECG abnormality, followed by prolonged QTC, and this is significant, and it may be attributed to direct targeting of myocardial cells by the HIV virus, which leads to localized release of cytokines and mediators. The indication of prolonged QTC is that it carries an elevated risk of life-threatening arrhythmias and increased mortality, and this risk is further worse right atrial strain. Okay, so in conclusion, ECG abnormalities are highly prevalent in adult HIV patients attending the RVD clinic in NAUTH Nnewi, and we had left ventricular hypertrophy, and patients that are found to have significant structural abnormalities can be referred for further testing, including echocardiography. Thank you so much.
Thank you. Philosophical and public health imperatives. Welcome, sir.
Repositioning psychiatry in Nigerian medical education to look at the history from the history of medicine itself. Modern medicine, as we see today, is structured into these different disciplines, just as we are witnessing, undermines educational quality, public health needs, and ethical obligations. So, educational theory, social and ethical justification for having full autonomous of evidence from what I've just presented now history of medicine, philosophy of medicine, epistemology of medicine, and medical education theory. Looking at the various documents that we have, the National College, West African College, and other parts of the country. These are the key findings from this review. The history and the institutional logic of medicine should demand specialization. See the beautiful plan to diverge. Philosophical foundations will require recognizing the mind as a medical domain and not just looking at the physique. That's what we see if you look at all these pieces of literature. And of course, educational evidence shows current training is very, very grossly inadequate. Even in our medical school here, there was a time we ran as low as 3 weeks. And if we look at it from the point of view of sociology and anthropological realities, there is need to have generalists who have competence. And of course, from the points of ethics and the profession, perpetuates the stigma we see in mental disorders. So, there is a mismatch. Public health realities in Nigeria, this heightens the stakes. Because without strong undergraduate education, am I ending? Oh, okay, I thought I was hearing sound. And of course, we need to expand the research, enhance community engagement, and align our country, Nigeria, with what obtains in different parts of the world. Undergraduate marginalization of psychiatry in Nigeria is not founded. When we look at the history of medicine, it has no basis whatsoever because everybody developed medicine itself. Nobody can defend that kind of stance that we have today. So given the development of medical specialization, looking must become fully independent with substantial curricula, completely different assessment, and institutional presence. This reform is essential. It's not something that's supposed to be optional. In order for us to improve national health outcomes and uphold the integrity of medical education. Thanks very much.
Thank you, Professor Wabke, for that to respond so that we can conserve time. Please, questions.
Dr. Okori, thank you for your presentation, but I have some bother. I noticed that the adults, have they had HIV? What drugs have they been on, and for how long have they been on those drugs? So these changes we are seeing, is it due to HIV per se, or due to the antiretroviral drugs, or both? How do we really explain that? Thank you.
I am worried about that sample size of 73. I know that somehow it can affect the power of this study. 5, how did you get, which formula, or rather, did you use?
All right, thank you very much. Please, my question is, I missed the full diagnosis, the extent of the injury in that patient. That will make me understand better at what point and how you had to come in. Thank you very much.
Doctor, it should be after, sir.
After?
Yes, sir.
Okay, thank you. My question goes to Professor Nduku. Your first presentation, you said sometimes, I'm hope that we are going to manage that, follow up that patient urologically for long, because they're actually at risk of having renal impairment. What if man is having not just follow up for the renal function? Thank you.
Thank you very much for that. We can start with the presenters. Please, Dr. Nduku, can you respond to the after?
Yeah, thank you so much for the question. The quality of life of the 5-year-old girl, like I said, of injury, I guess probably was other associated injuries. She fell down landing on the leg. Actually, if you want to pick it early, MRI is the investigation of choice. But most times we do x-rays. So even at 6 months, you can still see patient of lung. so that you'll be able to identify if there is any AVN. X-ray will show it late when there will be collapse of the head. So MRI is a test that will identify it early. Yes, that comment is well taken. Following the patient up. You know, if the symptom actually stops before then it's...
Thank you very much. Dr. Obai. Dr. Obai.
Okay, thank you for the question on the sample size. Actually, what we used was then highlighting other risk factors supporting it. So this is actually what explains the sample size selected. Thank you.
Thank you. Dr. Korea.
It was convenient sampling. So when we went to the clinic, anybody that was there were the people that we used. Okay, then some of them had HIV for long, some had for 1 year, some had for 30 years. So it was not within comparison groups. Okay, what I just presented here was just those who had HIV, but we also had a comparison group. So that was the formula we used, the formula for sample size calculation between two groups. Then that 61.8% was an ECG abnormality. Then I think those are the questions. Thank you.
Thank you very much. Professor Wakwe.
Sorry. I have a question for Professor Wakwe. You mentioned mental health and also psychiatry, which is a medical program. Therefore, join it to MBBS. What is your own advocate? Let me give you an analogy to help us. Community and social medicine. There was a time there was this, controversy when some of them started answering public. Expand your own impression. What do you?
Maybe I will just start from there and then incorporate what I wanted to say. Like University of Ilorin, in Enugu they call it psychological medicine. So people have all kinds of names, but these are confusing. The word is preventive, it is therapeutic, and it is rehabilitative. So psychiatry is simply an excuse like Nnamdi Azikiwe. We answer Department of Mental, not Department of Psychiatry, which is very restrictive. And what I was saying about reimagining psychiatry, I said it played out this morning. Overflow incontinence, which the other doctor did not mention. It was during the answer cure and ill session that Nduku now mentioned the issue of possible overflow incontinence. That medicine both overlaps and also segregates. And every discipline must be fully recognized in order to take into account what I said, the development of medicine. It's possible that these orthopedic surgeons may have been thinking about overflow incontinence with HIV. So there is both overlap and also a divergence. So we should respectively, fully recognize.
I thank the audience also for being actively engaging. Thank you very much.
The next segment will be chaired by Dr. Uche Ufaro. Please, let's give her a round of applause. Any medical researcher will find this to be a very good resource. So we are Ufaro, please.
Sorry, before the next session starts, please, the last presenters, can we have a group photo, please? The last presenters.
Thank you and welcome to the last phase of this scientific conference. We have Okechi Uchenna. Rural community in Anambra State, Nigeria. Ndule, you have 5 minutes.
mellitus among residents of a rural community in Anambra State, Nigeria. A cross-sectional study in Laurel, Nigeria showed that the prevalence of diabetes then was like about 1.something%. Food prevalence had increased to 5.77%, and by last shown by the studies by Oloko et al. And Olamoyegun. In Anambra State, we have documented has also shown that half of patients with DM seen in NAUTH have diabetic. And despite this documented burden in Anambra State, the community-based prevalence of diabetes in Anambra State is not known. For instance, if we look at this, sorry, let me get the pointer. If I had to determine the prevalence of diabetes mellitus among adults residing in a rural community in Anambra, in one of the towns in Anambra State, which are predominantly Igbo, just like other towns in Anambra State, WHO recommended stepwise approach to chronic disease surveillance questionnaire, and we define diabetes mellitus according to WHO recommendations. They recruited 391 adults. 249 of them were women. The prevalence of diabetes mellitus found in this study was 12.3%. Most of the diabetes association between increasing age and diabetes mellitus was statistically significant. However, although of DM, which is 7%, we got 12.3%. It's higher than the food prevalence rate for Southeast Nigeria, which is 4.6%, and it is also higher than the largest population of diabetics in the whole world. So we can conclude that the prevalence of DM among adults in this community is high and more prevalent among women. Age was significantly associated with diabetes mellitus, but the association with sex was not significant. Thank you very much. Okay, thank you very much. So I'll still follow the existing protocol, and I want to report on how the role of urine sediment in recovery of kidney function in a patient. Whenever a patient is on maintenance hemodialysis, that is no longer dialyzing for acute kidney injury, but dialyzing just for maintenance hemodialysis, that the patient is no longer expected to regain kidney function. And what usually in the hospital, that's 3 days a week in the hospital, and is very burdensome to bones. After he developed kidney failure, secondary to what was presumed to be infection-related, then a week after these symptoms started, he noticed bilateral leg swelling, hiccups, and drowsiness. So at this time, the doctor, due to logistic reasons, that's closeness to leg edema, the pulse rate and blood pressure were normal. However, the jugular venous pulsation was raised to the angle of the jaw, respectively, and both kidneys had loss of sinoparenchymal differentiation. Urinalysis showed 1+ of protein. There was trace leukocyturia. There was no growth in the urine. The repeats averaged above 1,000 micromole per liter. The serum, albumin, and lipid profile were normal. So we did red blood cell cast. These are red blood cell counts. We can see renal tubular epithelial cells. We can see different creatinine gradually decline from 700 to 499, 324, 200. By the time he got to 200, he discontinued. And in this case, urine sediment features of interstitial nephritis led to the initiation of immunosuppressants and recovery of kidney function. Urine sediment analysis has been described for different things. Recovery of kidney function in the setting of chronic hemodialysis has been described.
Thank you. Thank you for keeping to time. Can we have the third?
Okay. Good afternoon, professors, my teachers, seniors, and colleagues. I'm here to present a case of probable antidepressant-induced angle glaucoma. Okay, I'm here to present a case of... Okay, the authors declare that there's no conflict of interest and there's no financial. The one on the left is a normal disc. Here, the cup to disc ratio is about 0.3. This is just to help explain what the patient has. While the second commonest type is the angle closure glaucoma. Angle closure glaucoma refers to glaucomatous optic neuropathy as a result of mechanical blockage of the trabecular network by peripheral iris, resulting in raised intraocular pressure. It can be acute or chronic. Is commoner in Nigerians from a study that was done at Guinness Eye Center, Onitsha, where normal adults were examined. The chronic type was found to be commoner than the acute type. Angle closure glaucoma carries increased risk for severe visual impairment and blindness when compared to the open angle type of closure. Depression is a common disorder with a prevalence of 4.1. Antidepressants are commonly used for management of depressive episodes. Angle closure glaucoma, especially within the first week of starting selective serotonin reuptake inhibitor. While Manda antidepressant, here he compared the two medications. There is also evidence to show that higher doses and longer duration. A few studies, however, found no association between the use of selective serotonin reuptake inhibitors and medications should be avoided in patients who are diagnosed with glaucoma or who are at risk of having glaucoma. The possible pathway for increase in angle closure glaucoma probably induced by prolonged use of acetal in the right eye. She's a Christian and of Igbo ethnic group. There was no redness, no trauma, no aversion. Before coming to us, patient had a previous ophthalmic consult where eyeglass was prescribed. Milligram daily, which she takes in the morning, and also received amitriptyline up to 150 milligrams in the left eye. Refraction showed she was hypermetropic. The right had an error of 0.75 diopters, while the showed narrow angles in both eyes. Schaeffer grade 1 in all quadrants in the right eye, and Schaeffer grade 2 in 2 quadrants in the left eye. Intraocular pressure was 45 millimeter mercury in the right eye. A relationship between antidepressant and glaucoma. However, more local studies are necessary to further understand this relationship. In our environment, a good number of normal adults have narrow angles, which may predispose them to the effects of these medications. There is need for health.
Thank you.
Auditor AO. Electroencephalographic patterns in pediatric epilepsy, a 5-year review in Onitsha, Southeast Nigeria.
The encephalographic patterns of pediatric epilepsy in Onitsha, it's a 5-year review. With advances in management of epilepsy, we find out that more children across the gap still persist. The International League Against Epilepsy encourages or emphasizes the use of EEG-based characterization of planning and prognostication of cases. This is just a summary of the ILEA, that's in patterns in children with epilepsy, managed in pediatric neurology clinics in Onitsha, characterize the seizure types using the IELA guidelines, data on demographics, semiology, EEG findings, and syndromic diagnoses were extracted. The seizures were reclassified using the 275 children assessed. The mean age was 7.8 plus or minus 4.6 years, with a predominance of males, 61.5% of cases, while 5.5 people of the children had normal EEGs, and about a third of them, 33%, could not get EEGs due to financial constraints. Concerning the specific types, Hips arrhythmia was found to be mostly associated with epileptic spasms, while the spike wave discharges were linked to absence or myoclonic epilepsies. There were significant associations between age and seizure types and the EEG findings. And this graph shows the predominance of the generalized tonic-clonic seizures amongst the other types of seizures that were identified in the children.
A minute more.
The heat map shows tonic-clonic seizures in this age group, in this cohort, were predominantly generalized seizures. This mirrors the findings we find in many other low middle income countries, because most of the seizures we have in high income countries where we have more of the focal epilepsies. Also, this in a way contributes to the prognosis and the outcome. The EEG abnormalities, the yield was high in this case, about 61.5%, with the varying things like the hips arrhythmia, which was classic for the infantile spasms, and all the others. And this, to a large extent, informed the treatment options. For example, with those who had seizures, because some of them, when we had a repeat EEG, we were able to find out that they actually had seizures. Or clinically, we managed clinically. Missing EEGs is about 1/3 of the cohorts here could not get it. And it also contributes to our treatment equity or treatment gap. And it's something that needs to be addressed. In conclusion, generalized seizures is the dominant type of epilepsy in this cohort. EEG findings were EEG, improved access to EEG, subsidized EEG, and AI-assisted interpretation will help in the management of seizures amongst these children. Thank you.
Thank you.
Okay, thank you. I just got information that the first presenter will make his or her presentation virtually. So we are going to stream it now.
Please, can we have your questions for the presenters? As we wait for Okechi, can we have your questions?
Hello. Can I be heard?
Thank you, Chairman and the House. Okay, I want to congratulate all the speakers. We are women, but it's not a true reflection of the population because he studied, the people he studied. That's number one. Number two, I hope that going forward, like if he's going to publish this paper, that he will also who didn't know that they were diabetics. It's very important. Then generally speaking, about getting to the speakers also, when you're going for any conference, you have to look at the time provided for the presentation and try to squeeze your presentation within that time. When they start knocking, people now want to ask questions after your presentation. You can always use that to give clarifications. Then for Dr. Oji Chinasa, the slide also were not too visible to some of. So please, next time, look at your slide presentation so that it will be clear. You can see that others were very easy to read. Thank you very much.
So in Anambra State, and then Ubo was selected as the site. Does that represent Anambra State, the figures that you got? Or how was the sequence, how was the, what do you call it?
Thank you. Professor Wakwe.
Thank you, Mr. Chairman and the audience. Still on Dr. For systematic review does not take everything into account. You know there is what is called gray. It is systematic, gray literature on the study published elsewhere, but not available to you or not included. So it's difficult to use that word. There has never been malaria 1+, or what does it mean to say protein 1+? Can it be quantified? What is the clinical relief? This study was purely a prevalence kind of thing, not associative. But to say that age is associated, I mean, is another very, because there are so many confounding factors that make individuals to develop. We have not excluded the obesity, for example, either weight, or either had family history. We just say that the older individual again making a statement. Of course, we have a number of studies that were cited, people studying the relationship or rates of glaucoma in those who use antidepressants and so on and so forth. Causology in medicine is too difficult. Bradford Hill has criteria for saying that something causes, for example, in this part of the world, is probably this particular antidepressant that may be contributing. And of course, that case report was somehow a bit out of, I do not know. For somebody to be taking selective serotonin and then tricyclic at the same time, or maybe was it at different times, maybe when one.
My question, microscopy was done belatedly. It's as if it wasn't part of the initial assessment. It was when the dialysis was done. Subsequently, then you now have to do that. I just want to know, is it that, yes, I'm happy you talked about AI-assisted. Thank you.
Thank you. Dr. Anyoko.
So the first presenter and then the first presentation. Because it's a prevalence study, you know, I'm very much interested in your methodology where you talked about the test. So my question is, for those participants, you said 11 point work about those who are on certain drugs, because we know that may also confound or have some effect on the outcome of interest. Thank you very much.
Finally, Dr. Nwi.
Possible that because it's a rural setting, given the roles in the marriage or in the family setting, that the males may not necessarily, you may not necessarily have access to the male because they may go to find the bread for the family, and categorically saying that it's only in women. There may be other factors that may be responsible. My next question, since we are said to ask only 2 questions, my next question goes to Dr. Chinasa. Thank you for your paper once again. I just want to reiterate what my teacher has said. From the literatures and then from the WHO guideline, it is unusual. The WHO guideline recommends that. So, and then you did not specify the type of depression. I think it was important. Is it the first time or is it treatment resistant? Because this will give us better understanding to be able to understand why that patient was on the 2 classes of antidepressants and following the WHO.
Before they now respond, sorry, just for also Amala auditor, I think there's some misrepresentation of figures that might confuse us. The EEG they did, it's wrong to say that 61% of pediatric epilepsy patients had abnormal EEG. If the other 33 had done...
Thank you. Dr. Ndule, please, can you respond?
Diabetic we are women is similar to the last question I was also asked. Are older, the younger people tend to go to the cities and the men tend to live in the cities. So that may be, that may explain the demographic distribution I saw, and then the association with sex I saw. Then I was asked to make a distinction, okay, a comment, I should make a distinction between those who were aware. Yes, that will be done. Does this result across more areas of the state to actually get a more comprehensive picture? So we need a more comprehensive prevalence studies across both the riverine and then the urban areas and the rest to get a more comprehensive picture of the prevalence of diabetes. So how was the sampling done? I presented the sampling. We used a multi-stage multi-stage sampling technique in which we went from the administrative zones down to the villages. So we went through 4 steps actually to get to prevalence studies in Anambra State. Well, to the best of my knowledge, that should just clarify it that way, because I searched different databases. I did in a population in Anambra State. I didn't see anyone, but that is to my own limited knowledge, sir. What is the clinical relevance of 1+ of protein? Yeah, well, that's going to be 1+ of protein taken on its own may not mean anything. Glomerular basement membrane, or maybe inflammation somewhere in the interstitium. So 1+ of protein on its own is just saying there is damage going on somewhere from. So the next question was, urine sediment analysis wasn't actually part of the initial assessment of the patient. Patient was seeing a general physician before who actually commenced him on the dialysis in Kogi State. Then he now returned down to Anambra State because he's from somewhere close to Nnewi, and then that was where we got in contact with the patient and did the urine sediment analysis. I was asked about the first presentation whether those on glucose-lowering drug. Yes, the case definition I use, people who were already on glucose-lowering drugs for the purpose of treating their diabetes, as defined by that WHO stepwise questionnaire, we are included as diabetics. So I also included them as diabetics too. And yes, I didn't repeat the random blood sugar, so that is a limitation of my study. Ideally, I should have done that.
There is paucity of data on that, instead of saying there is none, because there may be one in an archive somewhere. So can we have Dr. Oji respond to her questions?
Okay, thank you.
They were mainly comments, so you respond.
Thank you for all the comments. Apologies on the quality of that slide. I think it was from the font size that was submitted. Okay, coming to the medication, the patient said at a point she took both escitalopram, not really prove a direct causal relationship between these medications and glaucoma. But the essence of this presentation is to create the awareness that there is need for further studies and also close monitoring of the patients when they are on treatment with this class of medication. The type of depression the patient had, we didn't get that information from her, but she just told us that she's being treated for depression. Thank you very much.
Thank you. Dr. Adita.
Thank you for your question. With respect to the first question, it was reflected in the limitations that this study was based on routine interictal EEG recordings. When we have repeat EEGs or prolonged video EEGs, or at least those ones, they are able to find out, they are able to increase the yield of EEG findings and also syndromic associations. Then abnormal EEGs and those who couldn't get EEGs in a total of 100. In the manuscript, it was reflected otherwise. We were able to separate those who had normal from abnormal as 100% without adding those who couldn't get it. And in that way, we found out that those who had abnormal EEGs were higher than the figures we presented here. But I had to respond to what was requested of me to present it in the way I presented it. Thank you.
Thank you so very much. We want to appreciate all the presenters and all of us for this session. Thank you.
Okay, so that's the end of our scientific session. Thank you very much. Thank you, Dr. Ufaro. Can the presenters please come forward for a group photograph? Thank you, everyone. When you are ready. Okay, Professor Gochuku, please.
The one was launched.
Left hand side, please. Thank you. Please? For females only.
Shall we leave the other one, the online one? I'll connect it. And it's you over the
OBSA. Dr. OBSA, please. Dr. OBSA.
Where did you?
By your side, if you walk out through fire, fire. Follow you stand inside the fire. Now love me, I go love. Now love us, we go love. Who go believe you when the whole world is calling you a liar, liar? Now love me, I go love. Now love us, we go love. No go to live your life to impress anybody. Cause some people ask with their large condom. Anytime you vex some, I go like when you hear this song. Me and you no be Jesus. So now only who love us, we go love.
We wish to use this opportunity to welcome all of us to the Nnamdi Azikiwe University Teaching Hospital Medical and Dental Consultants of Nigeria, the annual general meeting and scientific conference. The conference has earlier held, and the title. So reading these things now, becoming a real issue. Healthy doctors, safer patients, promoting mental health to this all-important event. We've been rightly informed that there will be awardees. Awards will be given to distinguished members of the association. And of course, our retirees will also be honored today. So I'm waiting for Dr. Victor Modekwe to get us the list and then give us the time to start. However, I can see our own Professor Nwakwe, who keeps to time any day, anytime, anywhere. And he's already here with our own Otugo, Ifemba, Okpo, our own alert CMD. Once we see him and we see our immediate part provost, we are convinced that what flying, alerts will be flying, and that is the best position. I can also see our former provost, Professor C.C. Ezechukwu, with O.H. Ekwunife. Whatever is happening there, I'm convinced either an article is being reviewed or journals are being launched. That table is indexed. That's an index table with high impact factor. I can also see Nkwerem somewhere there trying to hold our J.O. Ugu. Please, J.O. Ugu, I would like you to release Nkwerem. And your examiners stop talking once you leave. There's a problem. So I noticed they were discussing about Nkwerem's site. And I was telling them that this is our neurosurgeon. So Nkwerem, go back and collect your results. You might as well proceed home. They'll be discussing your prognosis. You know, when we came in, the presenters were handling it. And one thing I noticed that the stage was a little bit empty. And I was telling Weibo that this is one good thing about international presentations. You may get to that place by the time maybe they want to say you're not a hall. What you need to do is to stand on the stage, take good pictures, and send home. Go and present again internationally. Meanwhile, in a hall, also go on. Obviously, say the picture in such a way that there is nobody on the stage. You go for at that time, then on stage, you move, go down the auditorium. In any for the talk. So that is it. I can also see my Oga, my teacher, the Dean of the Faculty of Basic Clinical Medicine, our own Professor Kajetan Ilo. You know, whenever you Professor Comfort, whenever we see you, we are comfortable. Akujobi, it's a pleasure to have you in our midst. Thank you so much for all you do. Ladies and gentlemen, we also have here one of our retirees, a foremost pediatrician, our own father. Any moment from now, this program will start. And we wish to deeply recognize the presence of the man that will give the Jubilee Lecture on 29th of January 2026 at the ASU Auditorium, Oka. Professor Yang. Prof, it's a pleasure to have you. We are deeply preparing for that day. We've looked at the topic, and it means that all roads will lead to Oka on 29th January. It's our pleasure to have you in our midst. Dr. Gibson Chiejina, are we going to exercise here? Do we have the things for the exercise? Program bukan asyik. Oh ya, kayak ini ada cemong. Yes, yes. Doctor, our own DC Mark, permanent site and virtually everything. The man that whenever we see him, we are comfortable coming to the permanent sites. Dr. Chineku Anyoku, he's a good man. It's a pleasure to have you. Is that the table for management? Is that the table, where is the table for management? Where is the table for management? Let's get current research topic. If you're not ready, don't go close to that place. I can see our own Professor Jacinta Eloilo. Whenever we see her, we're immensely happy because she keeps getting younger as the stress in the country keeps getting up. Wow. Pediatrics, it is the same. They only respond to the stress in this country by getting younger. You can see Professor E.F. Ugochukwu walked in, and we never knew. We are talking about who is this young lady that just came with Dr. Nemchukwu. That table is scientific now. Yes. Dr. Ushe is very close to Dr. Mrs. Ezejiofo. You know, Ushe loves where power is. Ushe doesn't stay out of power naturally. He naturally gravitates. Ushe, very young, the people that get younger as the day progresses. So we are going to bring in more people to that table. Professor Eloilo, this table is for pediatrics. Okay, pediatrics, I remember. They can't age now from West African College to Asson table. Chief Eric Inyekwaba, it's a pleasure. With the secretary, that's Asson. The secretariat is coming home. Thank you so much for all you do. We are waiting for the chairman of today's occasion, who is our own Professor J.C. Orakwe. And once we see Prof. Sanya Orakwe, and he will happily write a check for us. So for the students who are not used to history, if you want to approach Prof. Sanya and you're afraid, we tell you the people you go to. Yes, this time they should meet out the yes. They should come so that we give them the history. The people to meet once you want to collect your dues and how to get around it. But they wouldn't come. Okay, not very close to Prof. So we are going to stop you. Leave Dr. Ugwe alone. Let's finish up with him. Follow me. Let's go to where your guy is. Wow. Professor. Chief Ebeni. Irapu Chief come exercise some. Ekwadosi can then screening for defense staff. Here is. Ushie, this one is not a gynecologist. In my way. Ona afiare bawa na enwe no sample ha sende. Ona afiare kete si na enwe no sample ha sende. Father send this go sample like that. You know, Chief ofu onye no. Amorom ka esi we handle ya. Chief Ezudu. A motion on the floor, Chief. And we can say stop motion. Even with everything is calm. And what are they when pot? Chief Okeke, it's a pleasure to have you in our midst. Ewo, okwaga win young. The Jija sign is a report na Diogo. When he came not here, get up there with the report and sign to go. Sign to go from on a show Obieje KG is like the standard unit for 4. Ojikwa receipt where nata. Ojikwa receipt. Chief Ugu. Mba nugo jiko receipt where nata. Ani enye receipt. I enye your receipt. Laminate ATN if not in Buruge again. Enye kwalumba nugo receipt. Mkwarem, you are not properly trained. This is where you should be. Mberi, it's a pleasure. Ladies and gentlemen, the chairman of today's occasion is here. He's no other person than Professor J.C. Orakwe. Prof, it's a pleasure to have you in our midst. The chairman of today's occasion, our own chairman. Whenever you see him, you know that the surgeons have come. Not that the surgeon is here, but surgeons high table now. Now that the chairman of today's occasion is here, survived. And all the ones that have impact factor. Give him any journal, 24 hours, it has an impact factor. Another 24 hours is leading. So we invite to the stage Professor Stanley Nnamdi. You people don't know that his name is Chinedu. Professor SNC Anyanwu, our own. And you can see how surgeons do their things. You can see we are talking about surgery. I know yes. Dr. Onyekwaba is trying to make sure that where the guy will sit has been screened properly. So we're sitting comfortably with our own boss, Professor J.C. Orakwe. Thank you so much for all you do, Prof. Lady convinced that by one word or other, the man will still release some alerts. More than we are aware. We didn't need to go on strike. We didn't need to disturb. Or just about to went to KC. Oh, feel no, not so happy. He just released alerts. 22nd December, 28th. Ifembo. Professor Anthony Igwegwe. Please invite him to the high table. He deserves very. When I can actually buy a park motor. Come on, they're going to put to that MDCAN chairman. They check it out. Chuck, I don't pay boy a park motor. More they play your line immediately from 7 p.m. I'm going to up where I'm not bragging anyhow. Manakwada one. Prophecy Igwegwe, the next day, Obia Waraki, Anachi was soon to go. That is how life should be. I'm going to come on, they're going to threaten them from everywhere. If I get my I am a my again, second tenure that I'll continue. Dr. Lazo Kafo, how far? And when I see it, we are here. If you look at the backstage, they're still begging people to take the breakfast. And we are resisting. It means that the lunch, the dinner, and virtually everything will be super too. Shall I invite to this? We invite one of the men that will continue to get young as situations get rough. Professor Gerard Okanando Udigwe. A round of applause as he moves up to the high table to take up the position that is rightly reserved for him. Prof has been here quite early. That he's in this hall this hour does not mean that he will not be in Birmingham in the next 2 hours. Or in US, Dr. Ugu, you are away. We can't hold him. He can catch the flight by 4 p.m. Says a picture from Australia. You now wonder how he made it. It's a pleasure to have you in our midst. Ladies and gentlemen, shall we invite to the stage our former provost, our former editor, secretary general, chairman, West African College of Physicians, Professor C.C. Ezechukwu. Let's move you up. Article can be reviewed later. Ladies and gentlemen, shall we invite to the stage the MDCAN chairman of NAUTH, Dr. Victor Ifeanyi Chukwu Modekwe. Let him get to the stage so that the one agitation on him, I'm so close. V.I. Modekwe. Ladies and gentlemen, shall we invite our retirees to come and take up their designed positions. First on the list is our own professor of pediatrics, our teacher, our mentor, a perfect gentleman, royalty by all standards, Professor Thomas Obi Olasi. Professor Olasi, whatever he teaches you, and you refuse to understand that there's a problem somewhere. In Ugu's voice, either you impervious learning or nepe we go kunisi. And to join him on that table too is our own Professor ACN Obi Okaro. Professor ACN Obi Okaro. And shall we also invite our own Professor AME Nwafo. Ladies and gentlemen, shall we invite to our high table our former digital dean, Professor Ebele F. Ugochukwu. No, Prof. In fact, the stage, they've been anxiously waiting for you. You're welcome, Prof. Thank you so much. And I'm also inviting to the high table one of the ladies that will also make the high table to be quite holy at this particular point in time. Our mom in the field of pediatrics, Professor Joy Ebenebe. Professor Joy Ebenebe, we're anxiously waiting for your arrival at the high table at this particular time. Professor Joy Ebenebe, if you want to know her powers, it comes once we come to the opening prayer. She brings down the Holy Spirit and she beautifies and sanctifies any stage. And she has chosen to go to the left of Professor SNC Ayaun. Prof is saying that she was her secretary. We are bringing her for other things too, to further sanctify that stage. And purify that stage. Ladies and gentlemen, our former acting Vice Chancellor is here in our midst. Akadile Nabagana, our own former DAP, former DVC, former everything. One of the best that ever took that position, Professor Joseph Ifeanyi Ikechebelu. Please, we are inviting Prof to the stage. Yes, that's the table for the awardees. Our own digital acting Vice Chancellor is in our midst. Shall we invite to the stage the man who is going to receive the award of recognition in defense of the medical profession? They call him Andoaka. Down here we call him Professor Bertrand Obinwosu. I saw him quite early. Professor and Dr. Mrs. Obinwosu. I know he'll be here anywhere from now. And of course, he's going to receive the award of recognition in defense of the medical profession. The next person is Professor John Onora Chukwuka. Professor J.O. Chukwuka, we're anxiously waiting for your arrival. And of course, I will invite to the stage Professor E.A.E. Afiadigwe. He has also been found worthy to receive the award of recognition in defense. Ladies and gentlemen, we all know that our sub-theme for today's event is investment opportunities for the Nigerian doctor, which will be taken by Professor Tim Uzoma Mberi. In his place, we have his wife, who is really here to give us this lecture with all the necessary ingredients it requires. Dr. Amaka Mberi, please come up to the stage. Dr. Mrs. Amaka Mberi is in our midst. She's going to take the presentation on investment opportunities for the Nigerian doctor. You see how surgeons do it. Dr. Amaka Mberi is an academic. She's a lecturer at Nnamdi Azikiwe University, Awka. And of course, she's actually part of us and part of the urology family. We're expecting the Commissioner for Health. We're also expecting other invited guests who shall be here in a moment from now to be part and parcel of this event. Ladies and gentlemen, shall we rise for the national anthem?
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign fatherland. Our flag shall be a symbol that truth and justice reign. In peace or battle honored, and this we count as gain. To hang on to our children a banner without stain. Oh God of all creation, grant this our one request. Help us to build a nation where no man is oppressed. And so with peace and plenty, Nigeria may be blessed.
Thank you. I will hand over the mic to Professor Ebenebe for the opening prayer.
Shall we pray? In the name of the Father, and of the Son, and of the Holy Ghost. And so, our dear Heavenly Father, most excellent Creator and Possessor of heaven and earth, we acknowledge your supremacy and your excellency. Abba Father, we thank you for the gift of life. We thank you for your benevolence. We thank you for gathering us together at this time to mark the end of year. We pray and thank you for the way you have guided us in the conduct of our jobs at our various duty posts. Our Father and our God, we commit this entire scientific session, lunch, dinner, exhibitions, all the things we have mapped out for today, we commit into your hands. We pray that you bless and sanctify all the domains, that as we partake of this exercise, it shall be to the glory of your holy name. In the mighty name of Jesus, we have prayed.
Thank you so much, Professor Ebenebe. Hand over the mic to the chairman for the breaking of kola nuts. May I invite our Chief Medical Director, Professor Joseph Odrichukwu Obaja, OON, ably represented by the CMAC himself, Professor Ogo Ezejiofo. Okay. Please, a round of applause. Oh, if I have a CMAC name move, a man a CMAC Abiago, the height, on the domain. When Ebenebe was blessing the domains, this is one of the domains. And I'm doing well size. I put on that maybe an actual CMAC. You can imagine no one could empower CMAC now. CMAC I know, but I seen a CMAC. Only you could know I have a CMAC. Our CMAC is here. If we case with energy, Abro C-Mark on gafe. I got mambo gafe. C-Mark, no. C-Mark, it's a pleasure to have you in our midst. Thank you so much. All the you make here. The representative of the Commissioner of Health Anambra State, who is not disposed to be in our presence, please shall we invite Dr. Obi, representative of the Commissioner for Health Anambra State, Dr. Obi, and we recognize in a special way Dr. Obi. Thank you so much, Dr. Obi, for being in our midst. Thank you so much for all you do. And we recognize the presence of the member of the Nnamdi Azikiwe University Council, our own former dean of 2 faculties, Professor Ivy Onyora. Professor Onyora, once you're set, the stage is ready for you. And I've been requested the stage there is for the retirees. And then Professor Ezechukwu will be sitting very close to Professor T. Obi Olase while we anxiously wait for the other retirees to come in. Thank you so much. May I now call on the chairman of MDCAN to hand over the cola. You are chairing MDCAN. You have to hand over the cola to our own chairman, Professor J.C. Orakwe. Thank you.
Thank you, MC. Chairman of Education and the buying Oji Abiakwa from MDCAN NAUTH.
Right. The buy Oji Abiagono. And I'm referring. The buy Oji Abiagono. If I die, go. I asked Lowe go for some time. Biko, I get well go do Oji. Nye Igwe Newi, onye Newi touches the bag I represent Igwe. Wojeli Oji. Obiolasi. Well, Oji, nye chairman MDCAN. And this year, well, Oji just CMD, more than a representative from C-Mark ever. Professor Nyara Neba, member of Council University. They were just Bia well Prof. Sigwebe, past CMD, honorable. Then, Chairman of the Board of Trustees, MDCAN National, Prof. Sanyanwu Okwaneba. Yes. Well, I the Commissioner of Health, Anambra, Dr. Ebili Kekwa, or representative. Well, Oji will tell me about. I will Oji, apart from the chairman, the oldest professor never. Oldest chronologically, not financially or by academics. Apart from me, by date of birth. How is it difficult to say? The retirees in now. Retirees in now. Let them decide.
Where is Ezechuku? Where is that? Near Ezechuku, let them protest. Give it to Ezechuku, let them protest. Then the awardees represented Prof. C. Ketchebel. Give it Ketchebel to represent them. The awardees. Prof. C. Ketchebel. Right. May we give to the representative. Now, Kedoziezi, as the word. Oh, come watch. The one that refer. Ejimojinaka. Kita no. Nas nan Georginaka. Ona welu ni foji. Amana emezuona. Na anabata n'ụzọ. N'oge edurukwa fa wee ebe a n'udo. Ka anyị na-afa wee nọkọkwa. A na-achọ onye ya awa ọjị. Onye ọwụna bụ onye Nnewi n'ebe a. Na-eche anya. Na-eche na ọtọrọ m ya bịa were ọjị. Mana ama na oye enwe. Maka na tebụl a nọ. I'm a retiree but not tired. So I'm a maro ndị Nnewi niile nọ ebe a nọ. I'm a maro ne so no mụ ya awa ọjị. Mụ ka o luru. So na-ekene Chukwu na tata. Ọ ụbọchị akara aka. Ọnụ. Wee nọlịa, wee ṅụlịa. Wee sị na arọ nke fọlụ nwantịntị na anyị anọtọpịa na o nwere ife ya eme anyị n'afọ Jizọs. Otu anyị si ekpe ekpele ka anyị si ekpekwa n'isi onye ọbụla ndị niile ndị na-enwere ike nọ ebe a. Ezinụlọ anyị niile ife ya adịla anyị mma. Ndụ nka nka nke onye ji ya welu zelu. Ya bịa ka Chukwu nọrọ anyị niile ka anyị wee nwee ike tọọ ọjị atacha arụ ike n'afọ Jizọs Kraịst bụ onye nwe anyị. Ise keketu. Then onye isi anyị CMD ị ga-agbara ya ọjị.
Okay, akwa wagoji now. Offer to Ribiere. Yes.
Chairman of
now. Ask of us Olibiele.
Thank you.
Thank you.
Ọfọ nke a ga-etigbukwa mmadụ. O lecha ifere na anasị asoro lee. O endigo.
Anyị mma. Anya ka nọgo na-arụ alụ onye isi njedebe banyekwa na nke 2026 igwetu nọkwuo ya lụọ onye isi njedebe. Ndị niile na-aritaya anyị na-abịa isi jisi ike. Etu aka na-ayọ Chukwu na-enyebe arụ ike. Anyị bụ Jesi ebe a, ịfụ Jesi ọ dịkwa ka lecturer 1. Anyị na-asị ka Chukwu nọnyela anyị ife na anyị ga-eme tata ka ọ gaa ọfụma ka afa nchapụta a ga-ejiwe na-eto afa Jizọs Kraịst. Anyị ayọ ọyị ka o mee ka ife mela anyị karịa ka anyị si wee yọ si na Kraịst dị nwe na anyị. Ifemba no Koneku. Otugo Newi.
Otugo Newi. Otugo Newi. What do Otugo Newi? Ghana Ganiwu. Now, Kita, Chairman, Board of Trustees, MDCAN. Professor Nyamunga Award, oh, sorry, Ndani Chichi, Anana Batata, nke Professor Ike Chebolo, na Nochita Yapa. Wejeli Ozikawa, Ofama Isokwi Bialeo, Nandi Achille Chichi.
Chairman Dallon, Iba I got sick of fossil EBL, Dallon.
All right, I got Gabazin. Right. So, well, I welcome everybody today to this the annual General Conference of MDCAN. I think I'm in the right position to welcome all of you because I've seen all of you before and now. Being the first chairman of MDCAN in this hospital, I think I have seen it all, and I'm very proud that the legacy that was left is still being carried on. I'm impressed by the arrangements and everything that has been done so far today and will be done during this conference. So I welcome all of you, and I ask all of you to relax. The programs will be carried out fast as when due, and then we hope to go in time to prepare for the next session, which is the dinner we have in the evening. So, having said that, MC, I'll be inviting Dr. E.U. Nwankwo for the welcome address by the Chairman 2025 AGM Planning Committee. Dr. E.U. Nwankwo, while we're waiting for him, may I quickly recognize the presence of the Director of Administration, Nnamdi Azikiwe University Teaching Hospital, Mrs. Ebere. Mrs. Uche Ugochukwu. You know, we are used to Ebele Ugochukwu a very long time. So we are gradually getting used to the other Ugochukwu too. It's a pleasure to have you in our midst, man. Thank you so much for all you. It's a pleasure to have you in our midst. And we also recognize once more the presence of another DC Mark, Dr. Chineku Anyoko. It's a pleasure to have you in our midst. And when the former acting Vice Chancellor came in, he came in with other consultants who are members of his entourage to receive this award. Dr. Mbanefo of the Department of Obstetrics and Gynecology. It's a pleasure to have you in our midst. Professor George Eleje. Professor George Eleje, it's a real pleasure to have you in our midst. And B.S. Toakpala, once you see his red cap, you know that there's another red cap that will follow. So his red cap is like a pre-pro. Is it not, Edemodu? Leo? So Dr. B.S. Toakpala, it's a pleasure to have you in our... By the chairman to invite to the stage our own Professor Ivy Onyora, member of council. He's sitting very far away from the stage. Professor Ivy Onyora. Please, once he comes in, we're anxiously waiting for his arrival at the high table. Dr. E.U. Nwankwo, plastic surgeon, chairman of AGM, please come and give us your welcome address. Welcome address by the chairman, AGM Planning Committee.
distinguished professors, colleagues, respected elders of our great association, our chairman, our guest, and honor that Gopad, project the address, please. It is with profound gratitude and great honor that I welcome you all to the 2025 Annual General Meeting and Scientific Conference of MDCAN NAUTH held here, a more prosperous future for the Nigerian doctor. This year's theme, Healthy Doctor, Safer Patient, Promoting Mental Health and Professional Wellness in Medicine, could not be more timely or relevant. As physicians, we have always been trained to prioritize the welfare of our patients, often at the expense of our own well-being. Yet the evidence before us is clear. A doctor who is physically exhausted, emotionally strained, or mentally overwhelmed cannot deliver safe, compassionate, and optimal care. Across the world, overstretched system, limited manpower, economic pressures, insecurity, and rapidly shrinking workforce due to migration. Continue to treat, then he or she must be healthy. This conference, therefore, calls us to reflect. How often do we check our colleagues? How safe are our work environments? How supportive are our institutions? And importantly, how intentional are we about our own well-being? We hope that the scientific sections of this AGM has provided actionable steps for building supportive systems, strengthening mental health resources, and creating environments where doctors can thrive, not merely surviving. Our sub-team, investing opportunities for the Nigerian doctor, is equally significant. While caring for our health is essential, hospital wards and theater, towards sustainable investment, financial literacy, entrepreneurship, and wealth building. Today, we will be exposed to opportunities and insights that can help cushion economic shocks, reduce financial anxiety, and empower doctors to build secure futures for their families. This triple celebration, AGM, Scientific Conference, and Senford Dinner and Award Night is also a moment of appreciation to our colleagues who are retiring, relocating, or transiting to new phases of life. We celebrate you. Your prayers, your years of service have contributed to the growth of NAUTH and the betterment of our patients. We say thank you, and may your next chapter be even more fulfilling in Jesus' name. Amen. To our awardees, congratulations. Your dedication, excellence, leadership, and hard work have not gone unnoticed. May this recognition thank you. Planning an event of this magnitude is no small task. Your sleepless nights, your sacrifices, and your commitment has brought us to this moment. Thank you very much for that sacrifices. To our sponsors, partners, and supporters, we appreciate your belief in our vision and your willingness to support medical professionalism and community health. To all MDCAN members present, thank you for your cooperation. Thank you. And I connect, learn, network, celebrate, and enjoy the evening. Let this gathering remind us that while medicine is demanding, we are stronger together, and together we can build a future where the doctor's well-being is valued as much as that of the patient. Once again, I welcome you all to this AGM and Scientific Conference. Thank you, God bless you, and may all have a memorable evening in Jesus' name. Amen. Merry Xmas in advance. Thank you.
Thank you so much, AGM Chairman. Thank you. May I invite the Chairman of MDCAN, Dr. Modekwe, to come and give us his welcome address.
The chairman of the occasion, Professor J.C. Orakwe, who was and is still my teacher, supporting us and advising and encouraging us and supporting MDCAN. Many of you don't know that Professor Yang is a union man One senior decides, Professor Ayanwu concurs. The Chief Medical Director, the Commissioner of Health, Professor Afam Obidike, every represented. Afam, who have been here, but emergency took him to Abuja, and yesterday he lost his father. So, represented by Professor Ogochukwu Ezejiofor, the CMAC. OBSC have said all that should be said about the CMAC. Also, I recognize him in his own personal accord. He is qualified and merited to be recognized. Professor Ogochukwu Ezejiofor, my namesake and my in-law, we're happy to have you around. The members of the youth management team, I can see Mrs. Joy Ugochukwu. Obviously, I've joined the management team. I hope it's true. Otherwise, he gets a query on Monday from the DA. DA, you're welcome. Dr. Odele, DC Mac Theater, Dr. Anyoko Chineku, the permanent site man. We are glad to be in your center and your zone. You're welcome. Very importantly, former CMD who employed me, Otugo Newi, Professor Tony Igwebwe. We are glad to have you. Former provost, former dean, former chairman of MDCAN, former head of ONG, and also my consultant under whom I did house job, Professor Gerald Udigwe. You're welcome, sir. Professor E.F. Ugochukwu, always available with us. We are glad to have you, man. Dr. Misimberi, well represented. She will be our guest lecturer. And Professor Audu, Moses Audu, not here, but virtually he's connecting to us. Professor Joy Ebenebe, we are glad to have you. You sponsored one of our game, Bible quiz, and it turned out to be the best game in our week. We're glad to have you here. Professor Onyora, I don't know why he's afraid to be at the high table. I don't know to be a fearful person. Prof will recognize you. Clinical sciences, I saw him here. Professor Kajetan Eloilo. Our awardees and retirees, Professor C.C. Sechukwu and Professor Tio Lassi. We are glad to have you. Some of the awardees are on the way. Some are held up by flight. Members of MDCAN present. Today is your day. Ladies and gentlemen, it gives me pleasure to welcome all of us today for this 2025 conference and annual general meeting holding at Classic Niche Hotel on the 12th of December 2025. It's a unique gathering. It's the last conference and AGM of my tenure, and actually the first I was able to hold in a full-blown manner. The crisis of last year did not allow us to hold it in this manner. The theme of this conference is Healthy Doctors, Safer Patients, Promoting Mental Health and Professional Well-being in Medicine. We have an eminent professor from JUTS, Moses Audu, who will give a thorough exploration of this theme. And I think she's a billionaire by now. You will hear when she stands on the podium. In this gathering, we'll be looking at our well-being and that of all medical doctors again. We are realizing that the well-being of medical doctors is very important for the safe management of the patients. The prevailing bias in the economy of the country in the past 10 years has taken its toll on the doctor. The ramifications are far-reaching, economically, socially, mentally, physically, and psychologically. We have therefore, in keeping with what we did last year, sought to explore ways of improving economic indices of ourselves. We may not all be able to japa, but we believe that those who see the importance of mental health for a safe practice. In this gathering, we shall be sending forth our veterans, our teachers, who have spent greater part of their time and lives saving lives and training doctors and specialists. These retirees deserve to be recognized, praised, and bid a good farewell while still alive as they sought to continue with other aspects of living. And persons of interest who have contributed in no small measures to the growth of our association and profession, and who have been partners with us in the service for the health of our people. We are honoring Professor J.I. Kechebelo Akachinemile for his resounding contribution to university administrations, to the support he gave to MDCAN while in university administration, and for taking reproductive health and gynecological medicine to the height of excellence, not just in this state, not just in the region, but in the country and the sub-region of Africa. Dr. Mrs. Nonye Soludo, the first lady of Anambra State, has spent a greater part of her time promoting of Soludo. He has been in the thick of success stories of that administration, and we have thought it wise to remember him and honor him for devoting his time for the excellence of healthcare. One of the characteristics of the end time, according to 2 Timothy 3:2, is that men will be selfish and ungrateful. And we don't want to be part of that. We don't want to be hard-hearted. Therefore, we thought it wise to select some men who have in the recent past invested their resources and goodwill to defend our profession. Medical practice have been hit from all sides in recent past. We are talking of men like Professor Bertrand Obi Mosu, Professor Varistus Afedigwe, Professor John Chukwuka, Professor Chukwudi Okani, and Mr. Dr. Frederick Okadigwe, who is a consultant officer and gynecologist and a lawyer. We shall speak more about them during the award ceremony. And their citations is in our brochure for us to take a look. We want to take the story of their exploits while they are alive and well. And I enjoin us to keep remembering our heroes while they live with us. We choose to also today to congratulate our Chief Medical Director, Professor Obaja ON, for securing a second tenure in office and for negotiating skillfully through the first tenure. He's our special guest of honor today. The beginning of his journey, our CMD was rough, but the journey became Dr. Ezekiel Nwankwo for going to a great extent to organize this meeting. And to all members who sponsored this event, we are too numerous to mention. A lot is packaged for this event, and it's an all-day and all-night event. Ladies and gentlemen, I therefore implore all of us to relax and enjoy today with us. You're all welcome, and thank you.
Thank you so much, the chairman, MDCAN. Thank you so much, Dr. V.I. Modekwe, for that wonderful speech. If you look at the program, it's time for special messages from special guests. And I wish to invite our Chief Medical Director, Professor Obaja, ably represented by our CMAC, Professor Ogo Ezejofo, to come and give us that special message.
The chairman of the occasion, so I won't go over that again. And then the distinguished members of the MDCAN family, Nnamdi Azikiwe University Teaching Hospital, Nnewi. The board and management of Nnamdi Azikiwe University Teaching Hospital, representing our Chief Executive, Professor J. Obaja, who is unavoidably absent on this very important occasion. The CMD planned to be here, but he is currently attending a very important meeting. The committee of CMDs are meeting currently, and he is deeply involved in that meeting. So because of his involvement in that meeting, he regrets not being present physically in this meeting, but he is with us in spirit. So I'm here on behalf of him to, first of all, thank the members of this distinguished association for the support the CMD and management enjoyed during his first tenure. Appreciative of the support from the members of this distinguished association. The CMD will not relent. He asked me to give this special message. One of the key things in his agenda is welfare. And when it comes to welfare, MD can top that. He rank top in his priority. and he will continue doing that in the second tenure and even do more. CMD is not going to relent on infrastructural development at the permanent site. The second tenure offers him opportunity to continue the good work he's been doing. The CMD is planning very hard within the next year to get up an infrastructure that will provide a massive office spaces for the MDCAN members, so that when people come to work, they will see where to sit and settle and do their work effectively. Apart from the lounge, which he has designated a place for, an office space is also coming very strongly, and that's going to be an office block for the MDCAN. So MDCAN is going to rank top, in his agenda in the second tenure. Infrastructure will continue. Strategic plans are living in drones. He's not giving opportunity for that to happen in a system like NAUTH. He offers, goodwill, free hand for recruitment as soon as persons are available, are exiting the training. That is strategic. That is actually to position the institution as one of the top ranking in terms of manpower delivery in the country. So he's not relenting on that. He's also not relenting in equipping the system now that we have available manpower, and they will keep expanding. The CMD is working very hard, to ensure that NAUTH rank top in facility, and that will happen in this second tenure of his administration. So the CMD wants to felicitate with members of the Great Association in a time like this. This is a time to relax, the end of year. He wants you to relax, all of us, relax in a very good atmosphere of cordiality, okay, of fellowship and comradeship with one another. Enjoy a time like this, the end of the year. It doesn't come very frequently. It comes once in a year. So if people have worked hard over the year, it is also time to the CMD and hospital management is fully in comradeship with the MDCAN of the institution, and we wish the institution a great time during this very important meeting, the AGM and Scientific Conference. Thank you very much.
Thank you so much, CMAC Giganticus. That particular about our welfare, Audrey, you had it. Anticipating. Thank you so much, CMAC, for all you do. With the approval of the chairman of today's occasion, may I invite the Commissioner for Health, Anambra State, our own Dr. Afam Obidike, ably represented by Dr. Obi of the Ministry of Health, to come and give us his special message, and of course, with the permission of the chairman, declare the event open.
Chairman of the occasion, the President and Executive Members and Medical and Dental Consultants, NAUTH Chapter, Chief Medical Director, NAUTH, distinguished consultants, eminent guests, ladies and gentlemen. My name is Dr. Ugochukwu Christopher Obi, and it is my distinct honor to stand here on behalf of the Honorable Commissioner of Health, Anambra State, to address this respected gathering of leaders, thinkers, and frontline experts in medicine, the MDCAN, AN, NAUTH, AGM. Excuse me. Sorry. Okay. It is a convergence of intellect, experience, and commitment to medical health and medical excellence. Let me begin by commending the medical and dental consultants of NAUTH. Your sacrifices, research, contributions, clinical leadership, and mentorship of the next generation of the doctors continue to strengthen not only the institution, but our entire healthcare system in Anambra State. Your work is the backbone of tertiary healthcare delivery, and your expertise shapes the health outcome of millions. Under the leadership of His Excellency, Professor Charles Chukwumasoludo, CF Anambra State, it continues to make deliberate and strategic investment in the health sector. Through the Ministry of Health, we have healthcare facilities across the state, strengthen disease and surveillance outbreak response, and public health emergency systems, digitalization and health information through the Anambra State Health Information Management Initiative, recruitment and training of healthcare workers to reduce workforce gaps, improved coordination with federal institutions such as NAUTH to create synergy in service delivery and research. These efforts reflect our unwavering belief that quality healthcare is the foundation of human capital development and societal prosperity. As consultants, you play a critical role, not just in patient care, but also in policy implementation, research, innovation, and ethical leadership. We see you as partners in progress. We invite MDCAN NAUTH. Sorry, excuse me. We see you as partners in progress. We invite MDCAN NAUTH to continue sharing expert insights to help shape health policy, supporting modern medical training and continuous professional development, championing research that directly solves local health challenges, enhancing mentorship to young doctors to curb the brain drain through professional fulfillment and career support. We also acknowledge the challenges faced by healthcare professionals, which is workload pressures, resource constraints, and the realities of a rapidly evolving medical landscape. Let me assure you that the government is committed to ongoing improvements in infrastructure medical care. Thank you, and I wish you productive and deliberation and successful AGM. God bless MDCAN, God bless NAUTH, and God bless Anambra State. And
AFAM OBDK, ably represented by Dr. Obi. It's really a pleasure to have you in our midst. Before I hand over the mic to the chairman of today's occasion, may I quickly recognize the presence of one of our foremost retirees. And his prof, it's a pleasure to have you in our midst. Thank you so much. And we recognize especially our former DA, Mrs. Nwafo. It's a pleasure to have you in our midst. Thank you so much for all you do. It is time for the citation.
So, ladies and gentlemen, having declared the conference open, I think we move further to these two things. Let's get the inspirations first. Then later in the evening, we have a lot of realization. You are still relaxing here, I'm sure. From the bustles of your clinics and the walls and everything, you are here sitting down and relaxing. So please, MC, can we move forward? Get the introduction of the suggestions.
Thank you so much. Our lecturer for today, the guest speaker, Dr. Nwebo, the stage is set for you to come and give us the citation of our guest lecturer who is already hooked up online for this first presentation.
We want to be sure that the man should be showing the man so that we see the man. This is just an abridged citation of Professor Moses David. Professor Moses David Audu, if you abbreviate it, that is MDA, Ministries, Departments, and Agencies. He was born in his pursuit of education started with primary school in LEA Gidanwaya Primary School, where he obtained first school living certificate in 1977.
He proceeded to Government Secondary School, Kachia, where he had both O-level and GCE in 1982. He didn't stop there. Professor Moses Audu proceeded to College of Advanced Studies, Zaria, where he had IJMB. IJMB is like an alternative to JAMB. He had that in 1984, and that earned him admission to study medicine and surgery in the prestigious Ahmadu Bello University, Zaria. And he completed that university pursuit with MBBS in 1990. Professor Audu did not rest on his oars. He proceeded further to do residency training in Jos University Teaching Hospital, Jude, and completed that in the year 2000. He also had a training in Harvard Medical School, where he had a certificate in GMH, specializing in trauma and recovery. Professor Audu is a man of many colors. He has a certificate from the from International Center for Credentialing and Examination, ICCE Hospital, which is now a teaching hospital in Jos, from 1990 to 1991. Had his National Youth Service Corps in Federal University Federal University of Technology, Akure, 1994 to 2000, and was subsequently appointed a consultant mental health physician in the year 2002. He later became an honorary consultant from 2004 when he was assimilated into the university. His work into academics started with appointment as lecturer 1 in Jamia University, Ethiopia. In 2002, he held that post from 2002 to 2004, and later joined the University of Jos as a lecturer from 2004 to date. He was made a professor in the year 2018. He is a member of many professional bodies, which are too many for all of them to be listed here. But among them is a member of Nigerian Medical Association. He's also a member of he's the coordinator, International Consortium of Universities on Drug Demand Reduction, ICUDDR, for West Africa. And is a member of coordinating committee for ICUDDR for Africa chapter. Publications in reputable journals and peer-reviewed journals. And among them is his study on homicide among inmates in Jima, in Ethiopia. Others include forensic psychiatry in Jos Prison and psychiatric aspects of psychological trauma, drug use among youths. He has other numerous publications. His contributions to training, Professor Audu has supervised over 14 dissertations and is currently supervising 2 PhD theses. He has done a lot of researches, as I said earlier, especially in areas of substance abuse. Professor Audu is not just a clinician and an academician. He also has a passion for rendering services to the communities. Among the works he has done to community care for inmates of Jos Prison, which he started from 2014 to date. He has other numerous community engagements, including television presentations, radio presentations, just to reduce substance abuse in the society. He has had a lot of both academic and administrative positions. Among them are director, is a program sponsored by European Union. He has been the coordinator for that program from 2014 to 2025. He has been the DC Mark Special Duties, Jos University Teaching Hospital, 2010 to 2012. He was also the HOD of Psychiatry in Jos University Teaching Hospital in 2007 to 2012. As He was the president of Association of Resident Doctors, JUT, from 1999 to 2000, and secretary MDCAN, JUT, 2007 to 2009, chairman MDCAN, 2012 to 2014. He is the board chairman of Mansa Foundation, Jos. He was from 2002 to 2007. He still has positions he currently occupies. He's presently the Deputy Provost of College of Health Sciences, University of Jos. He's the Medical Director, Serenity and Well-Being Healthcare Services, Jos. He's the Coordinator of ICU DDR, West Africa. He's the Master Trainer for UNODC, Volume C, and he's also a National Trainer certified Colombo Drug Advisory Program, DAP, both for Universal Curriculum Treatment, Universal Treatment Curriculum, UTC. He's the Regional Trainer on Women's Intervention for Substance Exposure, Comprehensive Care for Substance Use and Disorder. He's also a Global Drug Demand Reduction Trainer. Professor Audu, a man of many accomplishments, is married, happily married to one wife and has kids. His hobbies include traveling, reading, music, and documentaries. MDCAN and our members, I present to you our guest speaker, Professor Moses Audu. Thank you as we listen to him.
Thank you so much. I think the stage is set. He's already online. Thank you.
Okay. Good afternoon. The CMD, Nnamdi Azikiwe University Teaching Hospital, the CMAC, the chairman, MDCAN, NAUTH branch, and its ESCOs, senior colleagues. I had Professor Wakwe is there. Colleagues, ladies and gentlemen, I want to thank you for this singular opportunity that you've given me to talk to you about a healthy doctor, safer patients, promoting mental health and professional wellness in the medicine. I consider it a great honor, actually, and a privilege, because Professor Wakwe is so that we can understand what's happening, especially based on our experiences, mental health, and then generally, and then drug addiction. And I want to start with the introduction, the characteristics of poor mental health, what constitutes mental disorder. We talk about wellness. What do we mean by wellness? And then things that make a doctor not to perform at his optimum. Then from there, we'll talk about self-care for a doctor, and we will now can conclude. I don't know how many minutes I have for the lecture, but I will try to be as brief as possible so that I can give time maybe for questions or contribution from senior colleagues. Well, when we talk about health, even in the current dispensation and amongst colleagues, we mainly focus about on physical health. We rarely talk about mental health. I know there are a lot of stigma associated with mental health. Even those of us who are professionals in this field are sometimes stigmatized, unfortunately. And very few people talk about social health. So, but we know that man is a composite being, and we have compartmentalized health into physical, social, emotional, and so on and so forth. It's just for our own convenience, but the system works as as a unit. So, but when we talk about mental health, I want to give a small definition first. The one I enjoy using, the capacity to cooperate with others and sustain a close, loving relationship. And the ability to make a sensitive, critical appraisal of oneself and the world about one, and the ability to cope with everyday problem of living. I love this definition because it's very simple. And sometimes when I talk to people, I say, okay, when we talk about mental health, let's look at this and then assess ourselves or appraise ourselves in the light of this definition. Can we say we're actually enjoying good quality of mental health? Make sensitive, critical appraisal of ourselves. Because sometimes we don't appraise ourselves, and when people look at us and then tell us something about our blind spot, this is what to do, this is not right, this is this or that, we get, offended because we never actually take a critical appraisal of ourselves and find out whether what we're doing and think that whatever we do, whatever we say, or our opinion is always the best and it must be so, which is not true in of life. Can work productively and fruitfully, and the person is able to make or contribute to her or his community. Usually when I talk to colleagues or maybe to a group of people, I say, let's look at this. How many of us in Nigeria can actually say that we have been able to realize our own potential in the light of all these adverse socio-economic situations that we find ourselves? And how many of us can cope with normal states of life without, taking it on other people, accusing people of this and that, showing some aggressive behavior? Because of the insecurity around, you find that almost every part of the state, you find that the community there arranges for a vigilante to be able to secure the environment. And we don't even know our neighbors. Can we actually say that we're enjoying good state of mental health? That is the problem. So these are questions, pertinent questions that we need to ask ourselves. So mental health actually describes the capacity of individuals and groups to interact. Yes. Interaction is inclusively and equitably with one another and with our environment. Both physical, psychosocial environment, and in ways that promote cohesion, not bringing division, fighting each other, running down each other, and optimizing opportunities for development. And the use of our innate abilities. Have we been able to tap into our innate abilities, particularly in this part of the country? If you look at what is happening, people are not secure. People are living in fear and apprehension. They don't have the basic necessities of life. So how can they actually use their innate abilities optimally? If you look at Abraham Maslow's hierarchy of needs, how can you use your intellectual and this endowment well when you are trying to survive and trying to gain the basics of life, food, shelter, clothing? We live at that level. Many people in this country live at that level. So how do you maximize your abilities? And it reflects a state of harmonious relationship between members, or we're lacking in one way or the other. So good mental health is not just the absence of mental disorders, not at all. Therefore, it is the foundation for an individual's and community's effective functioning and well-being. You end up being a cognitive of progress, not only for yourself but for others, or for the community. So a person who is mentally healthy has a state of well-being in which one, as we said earlier, realizes his own abilities, cope with normal states of life, is productive, is able to contribute to community, and can express a range of emotions. Sometimes when we become mentally ill, our emotions are restricted. I work in the prisons because I do forensic aspect of psychiatry, and I try to work especially with the juvenile offenders, and I try to equip them with psychosocial skills that they need to succeed in life. And I try to test them and see whether they can experience or express or even recognize range of emotions, and you'll be surprised. Because the literature says that when people are traumatized, when people are living in pain, they don't, though they know it's fear, aggression, anxiety, and sadness. That's all. They don't recognize the differential emotions. So this is what we're talking about. And then people who are with mental health are able to engage with the world around them, and they also have positive, attitude to life. So people who are mentally sound, they use I messages. You don't usually accuse people or project your own feelings on people, accuse people of one thing or the other. You take responsibility for your actions, and then they cope and adapt to change. Anybody who cannot adapt to changes, the environment, then it's not started. But you know that when people are broken down mentally, change is not very palatable for them. Particularly for instance, people who suffer from schizophrenia. In fact, may be very stressful for them when they begin to introduce change to their routine. And then they can be part of a team. Do we work as a team? Or we're just very individualistic in what we do, and we don't consider other people? In fact, we are the cog in the wheel of progress of the team. So we use healthy skills in managing our well-being, then we have categories of people who have a poor mental. What are the hindrances, or what are the things that can hinder us from with their emotions, with their subcortical brain? So their frontal lobe doesn't really work much. They think with their emotions. They don't analyze issues. They don't act on logic, but they act on to the problem. We don't take responsibility for our problem, but rather, accuse others of causing the problems. And they're usually aggressive and passive. Some may be depressed or run from conflict. Because when there is conflict, you don't continue to run from conflict. You don't create it in the first time, but when it comes, you don't advise them. They know everything. So they are close-minded. And whatever they say stands. My late mentor said, they think straight, but they never think laterally. It's also a mentally sound that thinks straight and think laterally, and needs to run the group. If he's not the one running the group, nobody else can do it. So we talk about mental disorder. So when people are not mentally sound, they are likely to be mentally ill. So what is mental disorder? A syndrome characterized by clinically significant disturbance in an individual's cognition, or the way we think. Its emotion does not regulate emotion well, or behavior. So usually mental illness, expresses itself in either our cognition, our emotion, or in the way we behave. And this reflects a dysfunction in the psychological, biological, and developmental processes underlying mental functioning. Mental disorders are usually associated with significant to express it. So you can even come from a family where people are mentally ill, but you might not express it to die based on the way you live your life and the way you adjust to life. So a mental disorder, the lack of or problem, and primarily a consequence of social deviance or conflict with the society. Usually mental illness is also culturally defined, because what I may do here that may make me seem like a crazy person, maybe in Europe or in America, might not be in my own society, might be acceptable. And what they do there, when some of them come to Nigeria, we'll find out they behave like crazy people too. So mental illness is actually culturally defined too. And it's not the psychiatrist that goes to diagnose or goes to hunt for people who are mentally ill. It's the people who live with them who say, look, this man is going contrary to our norms. His behavior is a problem to us. We can't cope. So we want to know what is wrong with him. So they bring their own is just to assess and tell them what is wrong with him, based on diagnostic criteria, well-established diagnostic criteria. Then we'll talk about wellness. Well, it's a concept, but it's a composite one. And we look at it in different dimensions: physical, emotional, occupational, spiritual, intellectual, environmental, and financial. So when you talk about a doctor who is healthy, who is well, who can attend to his patients satisfactorily, You look at this state of physical state, you look at the person's mental health, and look at also this aspect of wellness, whether the person is actually well enough to be able to discharge his or her responsibility well. So wellness is a big word, it's a composite word, and we look at it that way. So people might say they are well, but if you look at it critically, you discover that they are not actually well. And people will tell you that I don't have hypertension, I don't have diabetes, I don't have so and so, but they're not mentally sound. So are they well? No. And if you look at the person in this as a well person and look at all these parameters, will you say the person is well? No. So it's a relative thing. We might be well to some degree, but certainly maybe not completely okay. So I will talk about a doctor. I want to look at the responsibility of a doctor in our own client. It's covered that a doctor in Nigeria, in fact, has excess workload, especially if you're working in government setting. You go to other clients, there are appointments, I remember people they see, people that book for longer period, whatever. Nobody works like a donkey that the way we work here. And even when people are, work so hard, they are remunerated for it. But here, you can work till you collapse. No commensurate remuneration. So, doctors here are stressed by their excess load and then inadequate facilities that we need to cope with. Facilities are not adequate, but we need to make do with what we have. And then poor organization of service delivery and inadequate remuneration, as I said earlier on. Unhealthy interprofessional rivalry. Every day is strike. One group versus the other. And usually the doctor is a common enemy. I can give an example of my university. Our medical college is not finding it easy with the current administration. We have problem of accreditation from MDCAN, and our dental students are in trouble because they have not gotten clinical accreditation. And the management, I can say despises, the medical college. They don't like us. You want to be CMD, and it's an exclusive reserve to be CMD. You want to come to university and want to be VC. If you don't have a PhD, you can never be a VC. You cannot be this, you cannot be that. And they come begging, they want their worst to be medical doctors. When you look at the publication in the university, in fact, those for the medical college top every department, every college, every faculty. Most of the good rating of the university even comes from the medical school. And when you talk about the workload, hard work, it was in the afternoon, morning, afternoon, night is on call. The rest go and be drinking their palm wine. All the papers, so do other things. They have how many lectures, maybe, in fact, the whole year, how many lectures they have. But nobody sees it. And nobody likes the doctor. So this is a big problem that we face in our own client. Yesterday, we were at the meeting of provosts of medical colleges, our annual general meeting, and we were told that, in fact, the Minister for Education has actually fought on our behalf and is gotten even approval. And even the minister, because he's a medical colleague, and the president to say, no, why do all maybe you work in the teaching hospital. If you look at your total take-home pay, can your total take-home pay help you to live comfortably, feed your family, clothe them, build your own good house, buy a car, and pay your utilities? It's difficult. But you are working, you are burning your candle at both and working so hard. But the pay is not commensurate, and yet people don't like you. So these are the problems that doctors face in this time, and in this part of the world. So, and then other things that might interfere, people like those of us from the north are actually traumatized. And the visible signs, palpable signs of trauma is what we are facing today in our society, the chaos and the anarchy that we face on a daily basis. is because people have been traumatized. And what is trauma? Simply defined by Walters, in 1990, it says an injury to the mind, just like you have an injury to the physical body that requires structural repair. And actually, the definition of trauma, as it says, a stressful event or situation of an exceptionally threatening or catastrophic nature, which is likely to cause pervasive distress in almost, everyone. So this is trauma, and the SAMHSA, substance abuse and mental health and physical, social, emotional, or spiritual well-being. So it says the event plus the experience of the event and the effects leads to trauma. So I look at it and I discover that many people, including our medical colleagues, are traumatized and it's actually affecting their work. So, but trauma differs from ordinary day stressors of life. What they mean by banditry, I don't know. We have witnessed, bombing by agents of Boko Haram. When they started, they were targeting churches, bombing us, and just had, in fact, experienced about 3 bombing episodes where, by many, there was mass casualties of people. One was just by the first of the teaching hospital, and the fence collapsed. Work on the following day, you find a leak here, you find it so terrible. Now, but this is not even a single event. We have witnessed this over time. People cannot sleep with their eyes open, especially in the north. And the problem of kidnapping now that has become a business, because that is the fastest way to get money. Kidnap people, that people are even self-kidnapping themselves. So it can be a chronic one, multiple traumatic events, which can be diverse and repeated, just like we're experiencing in the north now. And then trauma can be complex. So complex trauma is chronic trauma with 2 key attributes. It starts early, from 0 to 5 years, usually inflicted by adults who are expected to care for the child. And then when trauma during childhood, and the cases I've seen, colleagues coming, to compare on one another, but you can link everything to traumatic episodes, either in childhood or a single episode of trauma or whatever. And I discovered that it's a big thing that we don't really focus on. But many people around us, and the doctors are not excluded, are traumatized. In fact, even people like those who work in the oncology unit where their patients, many of them are dying, and then people like the surgeons here in this part of the world that have seen all kinds of cases where people are beheaded, where people, children are stabbed, pregnant women are stabbed and killed, elderly people killed, and all kinds of things. And then you go to theater, and you just repeated episodes have made some of them traumatized, but they never know that they are, traumatized until we had a talk and, profession. So even in our profession, you find that with this repeated emotional burden that you have to share, you bear, you listen to, before you know it, you become traumatized. And this is happening to our profession, to our colleagues, but they don't know. And they would tend to mask it, maybe drinking alcohol or doing some other things, or you take it out on your subordinates, the consultant takes out his residents, or take it, out on your children at home, your spouse. And we also witnessed that among most of our soldiers here who were sent to the Northeast. They came back and they were fighting everybody, fighting their loved one, beating their children, and they were completely changed people. They went into drugs, drinking heavily, whatever, because they're traumatized, but they never knew that they were traumatized. So that most important thing is defining feature is that extreme stress that overwhelms our capacity to cope. And the victims of trauma are not only the perpetrators or people who witness it or who experience the trauma. No, the victims include, in fact, the subjects of trauma include the victims who are directly hit, relatives who hear the story of how their loved ones were killed or were battered, whatever, and bystanders who even watch what happened. Yearly workshop. If you find many of the military men who attend the workshop will come and say, honestly speaking, we are brought in the office. It's a big problem where there's so much insubordination And I knew when I was giving pro bono services to the barracks, then one of the chief of army staff wrote me a letter to examine one or two of them who turned their guns on their commanders and killed them because they were traumatized. And they couldn't understand why somebody would just turn his gun on his commander and kill him. And many stories from the barracks, So even people who perpetrate trauma, the risk of post-traumatic stress disorder, PTSD. And my colleague here did his thesis with supervising. He looked at medical students and had a 23.4%, of trauma among medical students here in Jos. And in other class, they have different trauma here among doctors. Why are we talking about trauma? It affects, it's something that is self-defining, affects one's sense of self, sense of dealing with others, ability to regulate emotions, how one approaches services, and how one approaches the culture of the treatment agencies, work environment, and life in general. And especially if you look at children who have been traumatized, studies have shown with neuroimaging techniques. In fact, their brains does not develop much. It's only the limbic system is the one that develops because bigger, and they think with their emotions, they are governed by the limbic system or whatever. But the cortex, cerebral cortex, is shrunken. That's how, in fact, the whole thing is upside down. So it's not just a feeling, but there are structural changes even in the depression. Commonly, some will use substance use. Some will not even. Is just persistent anger, and they're looking for opportunity to take a revenge, especially if they think somebody, has done something evil to them and they were unfairly treated and there was no redress. So, but a few will come down with PTSD. And when we talk about post-traumatic stress disorder, I can tell you that till today, some of colleagues, some of our hospital workers who had this bomb blast. So people don't want to pass through those to have anything to do. In fact, not even television showing you or anything about trauma, or maybe they're having a documentary talking about trauma. Some people will not want to watch television because this reliving memories of what happened, and some cannot sleep, some cannot because we don't have time to go into this thing. But people commonly talk about trauma, PTSD as trauma, but trauma is much more than that. Some come down with PTSD, some never come down with PTSD, just depression. Some come with substance use and other things. But PTSD is the one that a lot of people come down with. And a lot of the soldiers actually suffering from post-traumatic stress disorder. Officers have been court-martialed, others have been court-martialed because of post-traumatic stress disorder, and they don't understand. I recall my colleague in the military said they were talking to one of their generals when they were court-martialing a very young, brilliant officer, a very gallant officer, but he suffered from PTSD. With every sound, he would just fall flat on the ground, take it as if he had dodging a bomb blast, whatever. So they say he was a coward, whatever. I said, no, sir, this man is not a coward. This man is suffering from what we call PTSD. And the general said, what is PTSD? Everybody's traumatized. He's a coward, whatever. I said, no, sir, let's not just court-martial this man. Because if you court-martial this kind of person and he begins to reveal many things about us, then we'll run into trouble. That's the saving grace, for that officer. But he was lucky because a psychiatrist had to intervene, and to treat him of his PTSD. So a lot of our colleagues, as I said, psychiatrists, a lot of surgeons, people working in oncology and others, they're actually traumatized. And for those of us in the north, even the mass casualties, you see, mass burials that we experience, and then bringing people in mass to the morgue or to the mortuary in the hospital, and when they bring in corpses and then people batter, whatever, that has traumatized a lot of people. To the extent that some people had to leave even the state, and some even left Nigeria and said they can't stay in this kind of country. So we are
My energy on high tension. I'm on fire. Thank you, government.
I think we've okay. I think we've lost him. Yes, I think we've lost him. So that we have to, with the permission of the chairman, we move with the second presentation. We picked virtually everything he has said. Ladies and gentlemen, distinguished colleagues, hope we are together. Hope we are together. Biesta, are you with us? Are you with us? Thank you so much. While we wait for our second presenter to come back, may we quickly recognize the presence of the NMA State Chairman, Anambra State, our colleague, Dr. Okam Princeton. Dr. Okam Princeton. Orderly is here. Can you come closer? So you can stay with Orderly. This is a high-powered table. Dr. Okam Princeton, please come forward. The second presentation will be taken on behalf of Professor Tiyum Berry by his wife, who is here with us. So once she comes back, she will take the second presentation. While we're anxiously waiting for her arrival, let's recognize the presence of our colleagues who joined while the presentation was on. We have in our midst Dr. Nwankwo Malaki. Chief, it's a pleasure to have you in our midst. You're occupying the entire table alone. It's a real pleasure. Yes. And we recognize the presence of Dr. Shelley Chukura. Shelley, it's a pleasure to have you. You're with Dr. Neke. It's a wonderful day to have all of you here. And we recognize in our midst the presence of Dr. Ngozi Okonkwo of the Department of Family Medicine. It's a pleasure to have you sitting on the table with Dr. Onyinye Okorie and Dr. Iranusi Chinyele. It's really a pleasure to have all of you in our midst. Thank you so much for all you do. Ladies and gentlemen, if you look at the program for today, the second presentation we have here is investment opportunity for the Nigerian doctor. This is a time for us to invest. We've been encouraged to invest. We've been encouraged to invest. There's a lot of reasons to invest in Nigeria. Dr. Ugo, hope you know. A lot of reasons. In case they catch you somewhere, you also use your investment. So there are a lot of reasons, especially now there are no more giving receipts when they catch you. So we really have to learn a lot of things about investment. And we have in our midst our own. She's always here with us in every program we do. Just that she's coming today alone. She's the wife of a foremost urologist, our own Professor Tim Uzoma Mberi, who has invested so much and had decided to be represented today by our own too, Dr. Amaka Mberi, who is going to talk to us on the investment opportunities by the medical doctor. Shall we welcome to the stage this elegant lady, as beautiful as how Unkwere people look. She is right there in our midst to talk to us on the investment opportunities for the medical doctor. It's a pleasure to have you, ma. Thank you so much.
Standing on the existing protocol, good afternoon, distinguished ladies and gentlemen. My name is Dr. Amaka Mberi. I'm here to take you through on investment opportunities for medical doctors, Nigerian medical doctors. Before now, as at the time my husband told me I will present this, I told him, nah, Ibiakwa, I'm very sure you would have done this. Maka amamnima saisi. I told him I don't know how to brainwash people, but I promise you I will try my best to tell you various investment options. But for me, okay, I think of wealth as a very important thing in life. Of course, the Bible said, money answereth all things. And so, without money, I don't think you'll be making any sense, isn't it? So we go to the concept of wealth creation. And what is wealth creation? Wealth creation is the process of accumulating income-generating assets over time with the goal of achieving financial independence and long-term stability. We are in Nigeria, and you don't need anyone to tell you that the economy is not. In fact, some people will say, may Nigeria not happen to you, isn't it? So there is need for you to actually prepare yourself and ensure you invest. And as medical doctors, you have every opportunity to invest first in yourself, and also to ensure that you obtain very important training. Training yourself, retraining yourself, and also make sure you don't depend on just your salary. Of course, everyone knows that salaries cannot make you wealthy. So we are talking about wealth here. Building sustainability or sustainable streams of income through investment, savings, and prudent financial planning will help you to be wealthy. Now, we have principles of wealth creation. First, you need to earn more money. Yes, you need to earn more than you spend. How do you earn? Firstly, you must ensure that you invest in yourself, just like we said. And also, you have to ensure that you invest in your business. Very important. I feel so sad when I go to some hospitals, and what I see, truly I'm not impressed. I asked my husband, I said, why is it that doctors don't have taste or what? Because sometimes you come to the hospital doesn't look good, the ambience is nothing to write home about, they don't care about the cushion, the chairs, old-fashioned chairs, everything is just old. And to him, maybe he thinks that you need him more as a patient. After all, he will actually help you to regain all your health back. But it's just more than that. Make sure you touch up your hospitals for private owners. Ensure you train your staff. Make sure you let them understand the business in medicine, okay? Because for your staff, people that are working for you, they need to look good. And you need to teach them the very important thing of how to do what? To attend to your patients. Those days in bank, if you're walking into the bank, we say, welcome to First Bank. How do you feel? If your staff can actually display them to your patients, by the time any patient comes in contact with them, they feel good about the hospital. And knowing that you know what you're doing for surgeons, knowing that you're not just good in bed, but you're also good on the table, is important. You make sure that you put everything together. Yes. So, by so doing, you are adding more money to your earnings. You may not know it because these patients will spread your gospel when you treat them well. Another principle is ensure that you save before you spend. We'll come to that. Make sure you save before you spend. Invest consistently. Diversify your investment. Do not put all your eggs in one basket. Make sure you diversify your investment. I will teach you that later. Start early. Start early to invest. Do not say, I'm too old or I'm too young to engage in investment, because by the time you start early to understand these various investment options, they will help you to grow. And then, how about maybe when you grow old, you just relax in your yard, taking sips of wine, and then making your passive income. Very important. So do not neglect it. You need to build an emergency stocks, bonds, real estate, and mutual funds while leveraging on compound interest. Okay, John Maynard Keynes is an economist, and to him, in his seminal work, which he published in 1936, he says there are 3 motives why you must keep or demand for money. And one of them is demand for money for transaction motive. What is transaction motive? You need money to carry out your day-to-day expenses. And then the second one is demand for money for precautionary motive. Why do you do that? Because these monies are meant to help you to tackle any kind of unforeseen circumstances that may come by your way. And then the final one is demand for money for speculative motive. That is actually where I am interested. Speculative motive. You demand for money because you want to actually take opportunities that may come by in form of investment. Sometimes you find out that these opportunities, for instance, just like somebody will call you and say, advantage of your future investment. Now, understanding investment. What is investment? By investment, we mean a strategic allocation of resources into financial instruments or assets with the expectation of making what? Income in the near future. In Nigeria, just like I said, you don't need anyone to tell you, to advise you to invest. As medical doctors, we are concerned about your future. We want you to live well. We don't want you, at the end of the day, you keep, rotating. I tell my husband, most of the times, all this money you're making is blood money. Because if you don't cut, you will not make money. But that's not true. With investment, you can actually sleep and then your money flows into your pocket. Now we have various investment options. Number one, we have equities. I know most of you will say, shares. Yes, equities, buying shares, taking ownership of different companies. Shares are good, but I will tell you later how to weigh your risk level. Buying shares of companies listed on Nigerian stock. By fixed income, we mean those kind of investment that has fixed returns. For instance, your treasury bill, your fixed deposits in your bank. You can say, yes, treasury bill for today is 17%. And at the end of the tenure or maturity of that treasury bill, you'll be able to get or calculate exactly the 17% of whatsoever you must have invested. So for fixed income investment, you are very sure. But remember, because of the new policy, from FIRS, you may not be able to get your 17% anymore. There is need for you to know that at the end of those investments, like your money market investment, that's, investing in treasury bill. And as medical doctors, our advice that you can actually take advantage of this. It doesn't have any issue because it is government backed. And then coming to corporate bonds. For corporate bonds, we have firstly government bonds and corporate bonds. For government bonds, these kind of bonds are being issued by government, okay? And at the end of the day, the government pay you what we call coupon. For corporate bonds, they are being issued by corporate blue chip companies. But I'm interested here how you can key into this kind of investment. Before you can access government bond, firstly, you need to open an account with your commercial bank, okay? And then secondly, you must have what we call CSCS account. You must have a registered stockbroker. For government bond, it has two types. You have the primary bond and the secondary bond. For primary, usually they do it, government can issue bond every month, and they do this through DMOs. We call them Debt Management Office. I think there was a time I went to Abuja, they have their office very close to NDIC. That's their head office. But through your commercial bank, through Treasury Department, you can actually access this kind of investment. For corporate bonds, you also have the bonds that are issued by blue chip companies, and later I will tell you how the tenor and also the risk inherent in this kind of investment. And then let's move over to mutual fund. What is mutual fund? Most of the times, when these corporate bodies want to access funds, instead of going to the bank, usually the bank may charge them up to 20%. But they won't do that. What would they do? They will now have to meet a fund manager, okay? These corporate bodies meet fund managers. And then by mutual fund, we say, you as investors, they pull a whole lot of funds from various investors, okay? And a fund manager will now decide where to put these funds. For instance, he may decide to buy shares or bonds or the likes, or any kind of financial security, okay? So that is what mutual fund is all about. It's just an avenue where so many people, give out their money, lend their money, and the fund manager, collects this money and invests them. For mutual fund, you don't have fixed income. You have variable income, because when these fund managers trade, what they do is either they make profit or loss. And whatsoever they make, they will allocate these to the various investors. So if you have mutual fund, just like I have with UBA Capital, and open up your app, you will see on a daily basis, they update their rates. The rate of yesterday may not be the same with that of today, okay? That is for mutual funds, so that when you invest, you don't expect fixed income like in treasury bill. Very important. Then we have also another investment option, real estate. At least most of us here buy properties, they buy land. Investing in properties for rental income, particularly in cities like Lagos, Abuja. But here in Anambra, just make sure you invest in strategic locations, okay? When you invest in strategic location, you can actually be sure of your rental income. And for me, instead of building or investing in residential apartments, you can actually convert it to commercial outlets where you have, because for residential, if you have 4 tenants, the probability of maybe you can go home and sleep, your money is coming into your pocket, 1 or 2 defaulters, no problem. So that is the idea between your investment. So you must ensure that you invest in commercial ventures. Then we have another type of investment called EFTs. For EFTs, we say they are exchange traded funds. This type of investment is being handled by the stockbrokers, okay? Usually, they look at company index and they invest in maybe stock, bonds, and all what's not. And then for your returns, and then you have investment in commodities. Commodities like gold. I remember those days. You can actually buy what will be now. So investing in those kind of things are good. And then for gold in the bank, you can actually keep your gold, your commodities. You open up a safe custody. You pay them just little money. They keep your gold for you. When they appreciate, you sell and make more money. It's very, very good, okay? And then for hedge funds, like you have unregistered companies whereby you monitor the market, and if dollar increases, take for instance, for dollars, you buy, or if it reduces, you buy. If it increases, you sell. You can actually make money. But that one is unregistered, okay? And you have to be careful so that they don't dupe you or take your money. So, but it's a type of investment. And if you calculate well, you make money from it. Then let us look at risk, various risks in investment. Why do I have to say that? Because I need you to understand the risk in investment. That will not deter you from investing, but it will help you so that you will be able to know what's the type of investment option to engage in. Now we have credit risk. Number one, when investing in bonds or fixed income securities, there is a risk that the issuer may default or may default on interest payment. So you must be very, very careful. There is a particular CP on ground now at 21% for CPs. Okay, commercial papers are just like an avenue where companies will borrow from you and pay you interest instead of going to the bank. So, but I sat down, I looked at their rating. It's not too bad, but it's not good, okay? For an investor, when you look at the company's rating, you'll be able to decide if you will business in that kind of company. Just put small, because the yield is very, very high. So that is how to assess the credit risk. And then for interest rates, you also have interest rates risk. Changes in interest rates, okay, could affect investment, particularly fixed income securities like treasury bill. Sometimes you find out that the interest rate on treasury bill could, decline. And because of that, investors may not want to, put in their money in treasury bill. They will wait and watch for the rate to go up. Another type of risk is foreign exchange risk. In fact, this one has really dealt with us in Nigeria. I don't know whether we'll be able to recover from it. Foreign exchange risk. For those of us that invest in FCY, that is foreign currency. Okay, I forgot to tell you, mutual fund has both Naira and foreign currency. It has both Naira and, let me use dollar, for example. you can actually, invest your dollars in mutual fund, and they will pay you interest, in dollars. Yes, they have that. FBN, UBA Capital, and even FBN Quest, they have that type of investment. So foreign exchange risk is very, very, it has actually dealt with us in Nigeria. So it will make investors to lose money, because given that you bought dollar at the rate of 1.5, and all of a sudden the thing drops to 1.3, you're losing almost over 200 naira on top of it, okay, when you do the calculation. So it discourages investors. Market risk. For market risk, we say is a type of risk of investment whereby you lose value due to economic depression, okay, and instability in the economy, including insecurity, all right? So this market risk is very important for you to consider. For some countries, if you are an international investor and they ask you to invest in countries like Uganda, I don't know if you want to do that, given that their economy is not strong. So you must consider this market risk before you place your investment. Inflation, increase in prices of goods and services has posed in January, 2 million naira, take for instance, can buy a car. But in December, because of inflation, 2 million naira. And then liquidity risk, okay? For some of us that invest in real estate, most of the times when you want to sell off the property, the land, you may not really see someone that will buy them off immediately. So liquidity risk is also a type of risk you consider. And the last one is reinvestment risk. Sometimes you may have gotten an interest as high as 20% in January, but in June the interest declines. So this reinvestment risk poses a problem to our investment. Then let me take you down to what is a financial market. Why do you need to know what financial market is all about? Because it will help you to know where to put your money, the type of market instruments, such as your stock, bond, and so on. And then they are categorized into two: your money market and your capital market. For money market, is actually a type of market where you sell short-term securities. You sell short-term securities because of the tenure, usually maybe between 3 days to about 365 days. That is your money market. And then for your capital market, it's actually a market where you buy your long-term securities, okay? Long-term, take it for instance like the government bonds. They can actually, span through 10 years, 15 years, and as the case may be. So your capital market, if you are planning to invest in capital markets, you just have to be very, very patient because of the duration, yes. And the yield is very high. The risk is low. Why? Because it's actually government-backed. And then we look at money market versus is a type of money market, and it has a typical maturity period between 91 to 364 days. What is the risk? The risk level is very low. Why? Because it has government backings. And then for your commercial papers, like I said, these commercial papers are being issued by blue chip companies. The MDCAN, theirs is 21%, 269 days, okay? So they can, actually the companies can mobilize money through commercial papers. It's an option. If you have good commercial papers, please invest in them. They are good for companies that are very, very strong with a very high rating. And then you have your repurchase agreement. This kind of repurchase agreements are done by banks. Most of the times, banks can decide to buy back an investment and give you a higher rate. At the end of this of the tenure, they will buy back that investment from you. Okay, what are you gaining? Or what will you gain? You will gain the interest on top. But usually it's for a very short period of time, usually 30 days. How can you assess this? You can liaise with your account officer. Anytime they have such, because it doesn't really come back. In this case, banks may decide to, buy foreign currency from investors just to engage in import or export, okay? And this is payable. They will pay you within the period, and it can last between 30 to 100 days. Then for your call deposit, back in the days in the bank, when we want to maybe close with a very good figure, we meet some of our customers who have very large amount of money in their account, but not in our own branch. We negotiate with them. We can give them like 2%, 3%, just to debit. It's an agreement between the bank and their customer, just to debit the account. And at the end of the day, the next day we return the money. Okay, what we do is that it helps us to close very well for that financial. We usually do this at the end of the year. And then we now give the customer maybe 3%. The next day we return the money with the interest. That's called deposit. It doesn't happen all the time, but if you are liquid enough, anytime they call on you, you can actually assess this investment. And then for your capital markets, like I said, you have the government bond. This government bond, type of government, that is, take for instance, whether that country can actually redeem in terms of whether they are liquid or not. In March 2021, Ghanaian government issued Eurobond. Okay, I'll come to that. I'll tell you what Eurobond is all about. They issued Eurobond, and you couldn't believe it. They couldn't pay. They defaulted a whole Ghana. Okay, most people bought that Eurobond. But to them, they have lost their fund. So before you buy this kind of investment, please assess high, risk. Why is it moderate? Just like government, if you are not sure of the company, they may not be able to redeem or pay back interest and even the principal on your investment. So please contact your fund manager anytime you want to invest, so that they will be able to assess these companies and tell you the ones that are good or not. And then the Suku is actually a type of Islamic investment. It's being governed by the Sharia law. Of course, they don't collect interest, okay? Sharia law do not collect interest on any kind of investment. But what they do here is to maybe collect collateral in form of assets. And at the end of the day, they pay back. Usually, for the Muslim day, I did not even get my money, I understand. But please, shares are good. After all, I even bought Zenith Bank shares last time. And after 2 months, I saw big alert. I said, what? I told my husband, are you not keen? He said, no. At the end of the day, he felt bad. He said, hey, I've lost. I said, yes. Shares are good, but you must be able to know the type of shares to invest. A particular country needs some fund, or even a foreign company needs some funds. What would they do? They issue what we call Eurobond. It doesn't mean European bond. It means that those kind of bonds are being issued in the currency of that government, that company, okay? So for you to be able to assess this kind of investment, what will you do? You need to have an FCY account, okay, foreign currency account, so that whenever this kind of investment comes up, you can key in. They are good. So far, you know the credibility of the company. Now, we've talked about fixed income. We've talked about fixed income from the fund and then back to the investor. So why do I have to raise this? Because you really need to know the kind of income you receive from your investment. Then we have the market operations. For the market operations under bonds, there are two. I've talked about it. You have the primary and the secondary. For primary issues, you have through your debt management, through the debt management office. And then for secondary option, you get that one through a third party, maybe through treasury department of your bank. Then let's look at rating. Rating for fixed income instruments. How do you rate these companies that you invest in? You know, it's very important you understand these things so that it will guide you in deciding where to invest. For ratings with AAA, okay, you know, according to S&P, S&P means Standard & Poor, and then Fitch rating. Fitch rating is an international rating company. If you check the rating of that company and it has AAA, just go home and sleep because that company has the highest quality ever, strongest capacity to repay your principal and interest. Great investor, you need to take risk at times because if you don't, you may not get back you may not receive high yield. So it's very important, but it's left for you to decide to know what you are going to expect. So for rating of AA, you have high quality. Yes, they can also pay you back. Very important. It's good. Rating with AA is very good. But when we talk about this rating, please, I don't know, it's just that Nigerian factor is something else. We also have a local rating by the global rating company. I don't know what they do there. Last time they rated a particular company and it turned out to be very bad. They had to rating, you have upper minimum grade. For BB, you have non-investment grade, high yield, or junk. In fact, it's all about speculation. That company doesn't have any credibility. Okay, they don't have credit worthiness because they may not be able to pay you back, even your principal and your interest. And then go down the line, you have the other ones. Who are the market participants? The market participants. For market participants, we mean those that participate in the markets. Take, for instance, you have the investment banks. They raise debt and equity capital. Then for your stock dealers, stock brokers, they are also dealers. They facilitate trade. You have the asset managers. The asset managers, they are just carry asset. I have personally used First Bank for over 15 years, FBN Quest, yes, for over 15 years now. And for UBA Capital, they have never disappointed. Anytime I need my money, give them 24 hours, 48. They include the SEC, the CBN, Central Bank, Security and Exchange Commission, and then the DMOs, your debt man. And then how do you assess these fixed income, these investments? How do you assess them? Just like I said, for your government bond, you can assess your government bond through the DMO to invest in these securities that are very good. What do? You just have to identify with them, open up an account so that whenever they have investment opportunities, you can key in. It's very easy. And they have app where you can monitor this flow of investment. And then for your rice, bamboo, chaka, that one is an online. Okay, that is it. I've talked about the United Capital PLC. And then asset managers like the Cowrie Treasures. Then let's look at diversification strategies. You don't have to put all your eggs in one. Spread your tentacles. You will make gain from all angles. And if anyone goes bad, don't worry, the other will cover up. So you need to understand the diversification strategy. By this, we have your asset allocation. You spread your investment, just like I said, in different classes of investment, like you buy stock, you buy government bond, treasury bill, just like that. Gain that comes in from there. And then your geographical classification or diversification. Here, you may decide to actually invest in UK, London, and all whatnot, aside from Nigeria, okay? But before you do that, please, you need to Nigeria. Don't put your eggs in only one basket. And then you have industry diversification, holding stocks. Okay, you have for industries, invest in holding stock in different industries. For your investment vehicle diversification, it means investing gradually, dollar cost averaging. What does that mean? It means that you invest every week, no matter what, no matter the rate. Keep investing, keep turning over. Okay, and then for active and also passive diversification. When you talk about passive diversification, you talk about your bonds. Those ones, the key players in the market, they don't need to do much, okay? Once you push your money there, you go home. But for active diversification, you have your mutual fund. The market players, they keep buying, they keep, shopping for available investment. So you diversify based on active and also passive. You must strategize yourself, okay? You have to discipline yourself. Ensure you save money. Ensure you save money. Nothing should take you unawares. As a medical doctor, you must plan every expenditure you make. That will help you to save money to throw on in your investment. And then fixed income, but keep investing. Shop for investment. Invest in various types of assets so that you can maximize your fund. Never you keep idle money, please. Never you keep idle funds. Place them in various investments. And then finally, combine fixed income with other asset classes for full portfolio strategy. So you need to combine fixed income with variable income, just like we said. Combine your stock, your bonds, your mutual fund, your commercial papers. Have various investments. Thank you so much. Thank you.
Wow, wow, wow. A round of applause. Thank you so much. The lecture was as elegant as a presenter. Our investments. Save before you spend. Then she talked about speculative motive. I think speculative motive should also be, you should also save for, when you're kidnapped, right? Is it part of the speculative motive? She didn't mention that very well. Speculative motive. 4 cousins. Only 10 cousins, so we presentation of awards, madam.
Okay, I heard of it today. I heard of it before. Yes, I'm glad and it's a privilege to present this plaque as just an sign of an award, a recognition for this beautiful lecture you are giving us. It's quite inspiring. We have money kept in various places and we don't know how to invest. And some of us are poor because of poor investment. Thank you, madam. And then extend our regards to Tim.
Dr. Nnamdi will come and receive on behalf of the team speaker to be delivered or given by Professor E.F. Ugochukwu. Dr. Wibo. Dr. Wibo.
This is an award of honor presented to Professor M.A. Audu ably represented by Professor Azikiwe here. In recognition of your outstanding contribution as thematic special lecturer for the 2025 Annual General and Scientific Conference of the MDCAN NAUTH NAUTH. We thank you.
Award ceremony. Some members of the high table will help us to. If you don't, he's been our teacher, a consultant officer and gynecologist, former head of officer and gynecology, former dean, former DAP of the university. DAP means Director of Academic Planning, former Deputy Vice Chancellor Administration, and two-time acting Vice Chancellor. In all those places he has been an administrator. If you go till today, his track records are there. It can be deleted, it can be cleaned. When you go, they say, "Kete will read this in his own time." You come to UNISIC, when you see the UNISIC going into IT, in appraisal, in this, in that, it's down to him. You may not like him, you may have your complaints, but the things he does and he has done, nobody is incontinent. If you have a doubt, you go to Life Hospital. Your doubt will be cleared. And we felt it's time to remember our own. The part of the problem we have is that we usually don't remember our own. We felt it's just, and has an interest in becoming the VC. Usually when people have interest in becoming something, they play low key if you bring anything that concerns their group. When you read the first paragraph, you say yes. And he helped to drive the former VC and had all the discussions for the administrator, an excellent reproductive medicine, and a good member of MDCAN. Prof, would like you to come to the stage while our board chair.
Dr. Joseph Ike Chebelu, Professor of O&G. You are supposed to be my no-chair. You're also supposed to be my son in many other. You are a gynecologist and not only an administrator. It is joy for all of us to present this. This is administrator only, not O&G. To present this to you, sir, for all you have done.
Their names, I don't know their name. Maybe you recognize them. Can you get them and recognize them? Do you have their name now? Okay.
Sustainable Development UNISIC. It's a pleasure to have you in our midst. And we also have Emeka Ike Chebelu, Deputy Bossa UNISIC. And of course, Sir Chidiebelu Nnanedu, Executive Director.
But they have a representative, Dr. Obi. We collect the award for the wife of the governor of Anambra State. Now we're giving Dr. Mrs. Nonye Soludo this award. It should have come last year. Time, her birthday period, sponsoring free health care, standard free care that includes surgical treatment and medical consultations. And I've gone about paying hospital bills to indigent patients who are trapped in hospital in NAUTH, in KOUT, and many places. And that resonates well with us, who get to encounter patients who are indigent and who are unable. Okay. Prof is grounded in these matters, so he wants to do it in a proper way. Yes.
Your Excellency, on behalf of
MDCAN NAUTH, we are very proud to be associated with what you do and would like to partner with you in future for the health of Anambrarians in every way that we can. Congratulations.
Prof, you see another one for the commissioner. Yes, that's yes. So the two of them will still be around. The next award will go to Dr. Afamben Obidike. He's not here. Obidike emergently went to Abuja yesterday on instruction of the governor. And then, like we said, he lost his father early hours of yesterday. He has been a true representative of the excellency, integrity, and honesty that we crave, and that they even won an award of up to millions of dollars from the WHO, giving them in Abuja. And our own Obidike was there. Obidike has been someone that when we call him on any matter concerning MDCAN, NMA, he answers. There's no attitude that he's a commissioner. He's available, and we want to say that he's a worthy ambassador of this house, and we are hoping and waiting to receive him back as soon as possible. So, Dr. B, you will come and receive the award on behalf of the commissioner to be delivered by our former provost and former MDCAN chairman, Professor Gerard.
For the various innovative steps you've taken to improve the health of Anambra State indigenes to the Ministry of Health. We know what you can do. As a matter of fact, we only loaned you to the state government. We hope to have you back a few years from now to rejoin our fold and continue to serve humanity as you were doing before you left. Congratulations.
All right, thank you. We will still go on. We have some more awards to give. It was not a small thing for us. It ensured that we didn't hold this AGM in this manner last year because our certificate and qualification were under threat by some politicians who wanted to get what they want to get by during our House Officers' days. If you ever ask House Officer to leave Labour Ward, Obi will descend on you. So he wants House Officers to learn and be a doctor and be seen as a doctor from inception. And to the Senate, he brought out his head and neck. The day he spoke in the Senate, if you ever, I have the record, if you listen to it again, it was as if he had another trance from heaven. The Senate listened to him. The acting vice chancellor then, in spite of herself, listened to him. And when you know to that day, when he made us Inu, there's a thing in the vice chancellor search team and selection team will be annulled. And that was a major turnaround for us in that battle because it mandated and involved everybody in the Senate, whether you like it or not, that the university is not part of this. And after that, he has continued to defend us and getting involved. He hasn't ended. He's still part of it. We need to ask Nigerian and say, your labors of years in defending us. We would like to call our sub-team speaker, Dr. Mrs. Amaka Mberi. Award and receive the award. To give to us, him. In fact, the wife is also around. So,
award of recognition presented to Professor B. Obinwonsu in recognition of your outstanding commitment
Thank you, sir. We would like to recognize one of us. He's not a member of this association, but he's an MDCAN member from Kowu Center, but he is an alumni of this institution. We were called on alumni, and he got wind of it. He put his head into it. Now, Okani had in their center a similar problem many years ago. In fact, they could not be promoted if you don't have PhD. And they called on people to help. Nobody answered them. MDCAN National abandoned them. But when we called, he said what happened to him will not happen to us. And he got involved. I never imagined I could have gone to those places, thanks to people like him. And when we needed people to go to court on our behalf, we are finding it difficult. Our council member, please come and help us deliver this award. And he's still in court on our behalf. He's still going, signing documents, appearing. He's well versed in court processes. So I think the judges know him, the lawyers know him, and it will give a lift to what we are doing. Well done, Prof.
Yeah, my president, you called a morbid person to give a morbid person an award. Thank you. I guess this award is well merited. It is an award from MDCAN. As we are so dangerous. And we give this award to Prof.
Thank you very much. We also like to, thank you, Prof. We also like to give an award again to another person who been of help to us. I can see the pathologists and alumni all coming together for this, not of this center, but from all the way from Park Lane, Enugu State University Hospital. His name is Mr. Dr. Frederick Ikenna Okadiwe. He's a lawyer, a barrister at law. We are too minimal that I'm ashamed to give it. In fact, some of his colleagues were angry, thinking that he collects the money and pocketed it for him. Incidentally, kept pursuing the process until he got to the court judgment for the Federal High Court Oka that specified that that advert of last year, September 12, 2024, was invalid, was obnoxious, and all our acting CMD, our CMD, represented by Professor Ezijofo, to come and offer this award. Mr. Okadigwe has continued to go on the court on our behalf. When the advert of 13 September this year came out, immediately he saw, he said no, to have to speak to our pro-chancellor that is unacceptable. And when the Okoye continued to go to court, Okadigwe is still in court with them, with 2 court cases on our behalf, still at no cost to us. We want to thank you for what you have contributed for the medical profession. Many persons will now appreciate it.
E.L. Okadigwe for standing with us when it mattered, for being an advocate, for us. Despite not being in our fold, you understood our plight and that you stood with us. It's your outstanding commitment, principled advocacy, and courageous defense of the medical profession. It's indeed awesome.
We would like to call on Professor John Chukwuka, a former MDCAN chairman, former area president of NAUTH, for another fighter for medical doctors. If you trace his days back as president of ARD, NAUTH, you will know what he has done for this profession. He can go on strike and lock the keys to go to him, go with him to negotiate for skipping in NAUTH then, under the chairmanship of, after that I fear Chukwuka in his way he makes arguments. He doesn't get angry, he doesn't get offended, he doesn't get flustered. So last year when we needed to go to court, our national board needed someone to present us in court. They said, give me one person. It was the lawyer at national level was the current NBA president, Afamo Sigwe. When they write something, Chuka will start showing them the errors, they're making the mistakes. It was so vast in legal matters. It was quite interesting. I felt he should have been in legal profession like Okadigwe and Osime. So he rescued us that day, and we were not embarrassed. When we had to go again this year, he was really available. He has studied our cases. He has photocopied past judgments that addressed it. He has sent to our son, Professor Joye Benebe, to help us deliver this award to Professor John Chukwuka. Mommy, we would like to have you. Let the pediatrics to pediatrics. So you get that on.
You all know Dr. Chukwuka. He's Professor Chukwuka. But you see, if you have any issue, any legal issue, he's not a lawyer, but he can perform better than any lawyer. Whatever advice he gives you, you know that even if you go to any legal luminary, that he will say, it's okay, oh, that is it. So it is very deserving for him to get this award. He, functioned very well in the course of our legal battle. So the Medical and Dental Consultants Association of Nigeria, MDCAN NAUTH chapter, is presenting this award of recognition of the medical profession with sincere appreciation from the Medical and Dental Consultants Association of Nigeria, MDCAN NAUTH Nnewi chapter, on the occasion of the 2025 Annual General Meeting and Scientific Conference. We hereby present the award to you, Professor.
There are plenty of pediatricians here. Please, where is Dr. Ekwogun? Dr. Ekwogun, we need you to represent Dr. Professor Afiadigwe. Is Ekwogun here? Okay, the boss. I said a former DCMAC, a former CMAC of NAUTH. Professor Afiadigwe, as of last year, was the president of Unizik Medic Alumni Association. When we had to defend our life and our certificate last year, advert of 12 September 2024 came out, and we taught it to resist it. It wasn't as if we had a prior plan of what to do. But we began to call on people that one of those we called was Professor Afiadigwe, his association as the president of alumni. When I wrote him, he called me that he will call a meeting of the alumni and will explain this matter to him, that he himself is on our side. He convoked a meeting of the alumni, both local and out. The alumni were unanimously resolved to take on this fight with us. Now, why I single out Professor Afiadigwe is that, if a president doesn't want to get involved, he's about to get involved, he knows what to do. I remember some association I called that they played hanky-panky. But Afiadigwe, where we manipulated and maneuvered those who were against us. So it's wise, it's important that we recognize Afiadigwe. What he offered his body, made them available to us. Alumni contributed money for us, millions of naira, and spent on this. They initiated a court case and brought in Okadigwe. Until today, they have offered all their name to still go on courts over this matter. So Professor Afiadigwe.
Oh, are you coming up? Well, representatives of Dr. E.A. Afiadigwe, who are also Afiadigwe 2025 Annual General Meeting and Scientific Conference. Congratulations.
tenure, and to say thank you to him for what he did for us in his first tenure. He is going to be presented by the CMAC, Professor Ogochukwu Ezejiofor. The CMAC Giganticus, we need you at this table. The CMAC, the second tenure. Now it's important, usually when people are sent office, we have complaints against them. We think they're not doing this right, they're not doing this well. It's good. I also have that. But it's also important we recognize what people are doing, especially in Nigeria and in our current Nigeria, where it is not easy to do anything, to get anything done. Even to get a salary can be very difficult. And our CMD, you see what they have done at Akamili, to move those funds from federal posts to us when we are not an APC state. We didn't vote, we are the 5%ers. And the employment he's kept doing into the consultants forum or fold. When you go to other centers, you know, structure, and they promise for an office, which we are still appealing to him, is giving us some privileged things, which I may not mention openly here. I will talk about list things he has done to us, things that I don't want to say openly. I will say it at the AGM. So, Otugonewi, if you will help us, he has CMD to CMD. So say thank you to all on our behalf to him. He will hear it from your mouth. Thank you, sir.
Yes, I'm happy again to stand here. And then this one is to present. It's not easy to get your second term in anywhere in Nigeria. But by the grace of God, you got it. And the MDCAN, I said, happy. The association and everybody, all of us, we are delighted that you succeeded. Congratulations and remain blessed.
Ladies and gentlemen, DC Mark accident and emergency. Please come closer. Dr. Wankwo, presentation is Professor SNN Nwosu. Professor SNN Nwosu is to be represented by Dr. Adora Oyeka. And the presenter is a coordinating DC Mark, Professor Ifa Adike. Dr. Adoro Oyeka is here, representing Professor SNN Nwosu.
This is an award of honor from Medical and Dental Consultant Association of Nigeria, exemplary professionalism, and compliments to the care of patients, mentorship, institutional growth, and an ideal of the medical profession with on the occasion of her 2025 annual general meeting scientific conference this 12th day of December 2025. We present this award to you, sir. Thank you so much, and God bless you.
Thank you so much. Shall we invite Professor C.A. Obiokaro, ably represented by Dr. D.C. Obuga Adesigo Okundi bandit negotiator.
Okay. Prof, it's my single honor and pleasure to be the one to present this to you. On behalf of the Medical and Dental Consultants Association of Nigeria, MDCAN NAUTH chapter, this is an award of honor presented to you this day, 12th December, in recognition for a fulfilling retirement from the Medical and Dental Consultants Association of Nigeria, NAUTH chapter. On this day, on the occasion of our 25th AGM and Scientific Conference, today being the 12th day of December 2025. Congratulations, Prof.
Thank you. So we invite them to come to receive the award, and the presenter is our own Professor Mrs. Comfort Akujobi.
Sir, Medical and Dental Consultants Association of Nigeria, NAUTH chapter, award of honor presented to Professor A.M.E. Nwofo in recognition of your years of dedicated service, and best wishes for a fulfilling retirement. A fulfilling retirement from the Medical and Dental of December 2025. Congratulations.
Thank you so much. The next presentation goes to Professor C.C. Ezechukwu. And to do that is D.C. Mark.
Boy, he like it. No, most was not.
Put your glass now, and then put your hands behind it. Put your hand behind it.
Okay.
Prof, C.C. Ezechukwu, in recognition of your dedicated service, exemplary professionalism, and the commitment to the care of patients. Thank you.
dimension. I'm on fire. Thank you, dimension. I'm on fire. I live my life for all my mates. I don't send your papa. In a foot up now. I live my life. In a cut up now. I love my life. True hearts of what now. I live my life. For the neck I don't know what I love my life.
Thank you so much, distinguished colleagues. Please, we have to specially register our apologies for Professor JKC Emejulu and Professor EAE Afiadigwe. They are inevitably absent because of their engagement at the College of Provost meeting in Abuja. Yes, AGM of the Provost. Professor T.O. Olase. Professor T.O. Olase is here and to present his award is our own. If you look at their caps, it really matches. Professor C.C. Ihegihu. Professor C.C. Ihegihu is a resource control.
Kai, this will go. I need to read this. Okay, sorry. Okay.
Bring it up.
Doing this presentation because the father of pediatrics is too big. You know, I'm in our team all the time. So again, actually, you know, but everybody knows the father of pediatrics here. He's one of the best pediatricians ever. He has trained, mentored, and modeled so many pediatricians. And the MDCAN NAUTH branch is presenting this plaque in recognition of all the good things he has done for the hospital, for the consultants, for the residents, and most importantly, for his small patients. They don't call them small, sorry. Adult small patients.
I don't work at you, why I no go chop.
Distinguished colleagues, ladies, shall we invite Professor Obi Okaro to come and receive his precious award, and to present this is Dr. J. gentlemen, we're almost there. Ahoma since he was the fourth cousin Engo.
I want to know the fourth cousin now. Okay, that's all.
Ahom, you weren't here now when the lecture was going on. So while we wait for Professor Biokar is almost there. He's being led by Dr. DC and Dr. Ahoma Mbanuzuru. So we invite Dr. J.O. Ugu to come and present this award, HOD Anesthesia and Anesthesiology.
Thank you very much, MC, the chairman of today's occasion. This is like Snelling's chart, so I may not read it. Consider it a luxury to stand before you. I have known you over the years since I started participating in MDCAN since 2012. You've been a committed member and a constant figure in our AGMs. So I had this singular pleasure to present to you for your recognition of your years of dedicated service, exemplary professional works. Hereby most respectfully present this award of recognition to you. Here it is, sir. Thank you, thank you.
All eyes on me, I'm on fire. Body is banging, I'm on fire. Skin is killing, I'm on fire. My energy on high tension, I'm on fire. Thank you, the man, I'm on fire. Stand tall like a stallion, I'm on fire. Can't stop me now, I'm on fire. Every day I've been winning, I'm on fire. My energy on high tension, I'm on fire. Thank you, the mention, I'm on fire.
If you look at the program, it's response for awardees and MDCAN retirees. And I've been instructed to invite our own Professor Kase Andoaka to come and give the response on behalf of the award recipients. You can see he's already on his way. Professor Andoaka, our own Professor Bertrand Obinwosu.
Thank you so much, Abacha. You must first, I think my task is quite simple. To mention that on behalf of the award recipients, those who the MDCAN and MDCON considered good to receive their own award, I want to appreciate the members of the high table, the chairman, the outgoing chairman of MDCAN, my fellow recipients, and of course, you in future. As long as you have trusted in us, we are going to do what? Continue representing you well. With that in mind, I still want to say one thing. When I was called up here, people thought that here is Professor, Associate Professor Amaka Obinwosu. Yes, that's the compound name. So thank you very much. And I can only say that I'm very glad to be here. Thank you so much. Good.
Thank you so much, Prof. One thing you must appreciate about ONG professors is that they keep getting younger as the conditions of the country get worse. Oddly, you're asking me what is responsible. Invest in Eurobond. You've not invested. To come and give us a response on behalf of our retirees. Wow. Our own big brother.
My dear colleagues, I want to thank you for this day. What had just happened this afternoon is the end of a generation. Only one person that is still remaining in the clinical class, that is Professor SNC Anyanwu. Once he retires, our generation is gone. So I thank you so much for giving us this opportunity. When we came here very early, late 80s and early 90s, we never knew that today. I recall Professor Gabe Ezilo, who was our CMD at the same time the provost. I also recall Professor Olase. Professor JC, I thank you. Professor Olase, I thank you so much. You will never know what happened. Professor Anyanwu was the first staff of this college. Professor Anyanwu was the first staff. So this is our generation. Our prayer is to see that this place continues to grow. I thank all of you for this respect. Thank you so much.
Dr. Princeton Okam, to come and present the award to the chairman of today's occasion, our own Professor J.C. Orakwe, Professor of Urology. Professor of General Surgery. This is Professor of Urology. NMS State Chairman, thank you so much.
Thank you, Able MC. I think this is the climax of the presentations, and I have the singular honor as a father representing the NMA president. Prof, I think you can NMA in the capacity of the state chairman to present this award to you. This is a token of appreciation for gracious service as chairman of the opening ceremony of MDCAN NAUTH Conference and AGM 2025. Your support and dedication have enriched the gathering and strengthened our professional community. Congratulations, Prof.
Odile, come and take picture. Nkwerem. Nkwerem. Kebe Nkwerem nokwan. He was there. Kebe no na agba oga. Thank you so much. Thank you so much. NMA chairman. I'm being a threat to Niger report more than to NMA national chairman. More than has been doing cases for almost 1 year now. And once we for your laughter tonight, therefore he's ready to start going to court. So Rapuka more than he can hear 6 months. Olozo say a lot of things. Now the legal world. He challenge more than is too free now. Thank you so much. So you want to Kenya from June. You was you can report. So you report more than now. I got it so fresh. I want to say any war. Thank you so much. May I invite Dr. Oriji, the MDCAN secretary. Dr. Oriji.
MDCAN. And I want to maintain the existing protocol because we are having, we are already running out of time. I want to appreciate our guests and everybody, my colleagues who are here. And I will just read. Therefore, on behalf of the member and executive of MDCAN NAUTH, I wish to thank God Almighty and congratulate ourselves on a successful tenure Academic Conference of 2025 AGM. This AGM was made colorful by preceding indoor and outdoor competitive games. In this AGM, we send forth our retired colleagues and teachers who have made immense contributions to the well-being of humanity in the field of medicine. There are Professor T.O. Ulasi, Professor C.C. Ezechukwu, Professor S.N. Nwosu, Professor C.A. Obi Okaro, and Professor A.M.E. Nwofo. And also in this AGM, we gave meritorious award to Professor E.A.E. Afadigwe, Professor B. Obi Nwosu, Professor J.I. Ikeshebelu, and Professor J. Sponsorship of our members. In a special way, we appreciate Professor J.C. Orakwe, who despite his busy schedules, accepted to honor us by chairing this occasion. Similarly, we thank our visionary CMD, Professor J.O. Ugwaja, OON, the special guest of honor and the chairman of AGM dinner, Ochina Watawan. To our erudite speakers, Professor M.D. Audu from faraway Jaws, my mentor, my teacher, the man that coordinates the mind. And Dr. T.U. Umberi, we are grateful for your time and minds recalibrating lectures. To the researchers who really made the conference really scientific by submitting their abstracts, we appreciate you as well. And to all our guests, we thank you for coming, and we hope you shall find time to come again. Our committees, especially the continuous medical education, all of us will testify to that. And bylaw review committees, the jobs were excellently executed. To Ezekiel Uche Nwankwo, our social secretary, you did a good job. And finally, to the 2024-2025 executive led by my Dr. Victor V.I. Modekwe, of Bat Road 1, I am glad to be part of your team. I wish you all in advance a Merry Christmas and a prosperous New Year 2026.
My chairman, MDCAN, chairman of the local organizing committee, ladies and gentlemen, I think it's been a very successful day. We are coming to the end of today's function, but it seems like I will want it to continue, and many of us will want it to continue. I can see everybody still well seated there. Well, we must go. The function has to come to the end, but it will be on record that this is one of the, again, for the second session, which is the dinner, for relaxation and more. So while we leave here, we are just going to change, refresh, and come back for the dinner. So ladies and gentlemen, may I declare Dr. Ugu Jidofor, give us a closing prayer.
We honor and thank you for your mercy and your grace. Thank you for the success of the morning session of this day and the events therein. Thank you for health. Thank you for vitality upon all those that participated in one way or the other to make this a huge success. Thank you for wisdom. Thank you for the clemency of the weather. Thank you for insights and direction. You have preserved and you have kept them. Thank you for one moment we have shared. Our hearts are filled with gratitude. We pray that you receive all the glory, honor, power, and majesty, for we have prayed in Jesus' name. In the name of the Father, and of the Son, and of the Holy Spirit. Amen.